So we are live in 5, 4, 3, 2, 1. We are live now.
Thank you. Good evening, dear friends and colleagues. On behalf of the West Zone of the IOA, we welcome you all to this webinar on hand surgery, part 2. We are having these webinars in a series of 3 sessions. The previous Sunday, we had it on soft tissue, on office orthopedics. Now we're going to have it on soft tissues. And the following Sunday on bony injuries. On behalf of the President of the West Zone of the IOA, Professor Ajit Shinde, the Secretary of the IOA, Dr. Thakkar sir, and of course the dignitaries of the MOA, and on behalf of the team of our colleagues at OrthoTV, I welcome you all once again. This webinar has been the brainchild of the President of West Zone of the IOA, Professor Ajit Shinde, and I'm very grateful to him for having given us the opportunity to conduct this webinar. We have with us faculty from all over the West Zone, as well as some of our colleagues down south. We have with us Dr. Latheesh Leo from Bangalore, Dr. Ashwin Lawande, Dr. Kiran Ladkat, we have Dr. Deepak Malokar, we have Dr. Terence, he is yet to join. We have also Dr. Ashwath Acharya, who will be joining in a short while. And then, of course, we have Dr. Ashok Ghodke from Navi Mumbai and myself. And we will be discussing a wide spectrum of conditions and issues and very practical kind of tips and tricks about these problems. So without further ado, I would like to invite Dr. Latheesh to please take over and start his talk. Thank you very much.
Good evening. Thank you very much, Abhijeet sir, for inviting me for this West Zone IOA program. I think last week, Ajit sir had come here, and then he asked me whether you'd be interested in being a part of this. And then I am here. So you can see my screen?
Yes, yes, we can.
Yes, we can.
So I've been asked to speak about fingertip injuries, decision making. So with this, I'll go into this. I bring greetings from Bangalore. So this is the overview on which I'll be talking about. First of all, you need to define what is a fingertip. You need to have a classification which will help you to design or decide about what treatment is best for that injury. You have our aims and the goals to attain and the decision making itself. So by definition, fingertip injury is the part of the finger which is distal to the insertion of the flexor and the extensor tendon. So which includes the nail plate and the nail bed, then the pulp and the distal phalanx. So if you look into the classifications, there are innumerable number of classifications which are coming to work. We started off with the Latheesh 1977 classification, where it was more of an anatomical classification. With the advent of microsurgery from 1970 onwards, the impetus was more on to replantation, revascularization. So most of the classifications started including the importance of vascular network at the pulp level. So we have the Allen's, the Tamai, the Erasis, and the Rosendale classification. So if you look at the Rosendale classification, it has divided the classification as about 2 parts. One is about the anatomical zone in which the injury has happened. We have distal to the phalanx. Then we have proximal on the middle part of the nail. Then you have proximal part to the lunula. Rosendale went on to classify the fingertip injuries based on the anatomy of the wound, or the way the injury has happened, dorsally directed amputation or crush injury amputations, and then you have a transverse, when you have a volar or a radial or an oblique amputations, which will help us, or which is going to help us in deciding what sort of flap is best for this sort of an injury. There's the newer classifications, which is giving more importance to the vascular network, which helps us to tell us which artery, where to look for the artery and the veins. We have the TAMAIS classification based on the vascular network. And most of the time I follow this classification, which is Allen's classification, which takes into the criteria about the pulp loss and the way the wound is there, and the phalangeal fractures and the vascular all come summed up together. So main aim when you're treating a fingertip injury is to preservation of length as much as possible. You need a durable skin at the pulp area. We need to have a normal sensibility, which the patient was having before, and the appearance is to be of a given a lot of importance. To attain that aim, or to go into that, what you're looking at is the goal, what we can get. We don't want a neuroma, we don't want a hypersensitive finger. Appearance, as I said, should be normal. We don't want a cold intolerance, and 2-point discrimination to be as normal as possible. So we have a wonderful recent outcome evaluation score, which was proposed by Terence, which has been published recently, which takes into all these things in the criteria when we try to evaluate a patient who has been treated with a fingertip injury. So I thought if at all we have to discuss about fingertip injuries, we'll take up different clinical scenarios, because mine is about decision making. So I classified the injuries, what we normally see as nail bed injuries alone, crushed fingers where there is minimal tissue loss, amputated parts where the part is available for us to do something, and where the finger is amputated but no part is available. So nail bed injury is nothing but injury to the nail bed which is there. And if how you diagnose a nail bed injury, when you have an subangular hematoma like this, when the vascularity to the nail bed has been affected, or if you see a fracture of the nail plate, you see and take an X-ray if you see a fracture of the distal phalanx, or you have a pulp laceration. Together with that, there is a laceration of the nail bed. Then what do you do when you have a subangular hematoma? So this is what we normally advise. If the hematoma is less than 25%, maybe you can have a conservative line of management. If the laceration or the hematoma is 25 to 50% of the visible part of the nail, you can go for a trephination. This will help to relieve the pain which the patient will be having because of the hematoma is developing between the nail plate and the nail bed, which is a tight compartment. You can use a sterile wide bore needle, make a small drill, make a small boring into the nail plate so that the hematoma can be let out. If the hematoma is more than 50%, we need to always expect that there is a nail bed injury. So the best treatment possible for him is to do a nail plate removal. You repair the nail bed injury, and then you can replace the nail plate, which will act like a splint. And the more important things about doing this is, it doesn't come into my talk as such. It is about using the material which you are going to use for nail bed repairs to be an absorbable one, ideally a 5-0 or a 6-0. So in this case, there was a fracture of the distal phalanx. That was a wound, what you are seeing there. So the nail plate was removed. And then you can see that there was an injury at the lunula level, which has been adequately repaired. If we have a nail bed laceration with pulp laceration, after debridement, we can go for a repair of the nail bed, followed by repair of the pulp. Sometimes this injury comes where there will be avulsion of the geminal matrix of the nail bed, which will be pulled up, and you have the epineural fold which is coming, which is preventing the geminal matrix to go back. If this sort of an injury is not identified, you'll go for a chronic wound there. So the ideal treatment is to replace the geminal, push the geminal matrix back into its place, lift the epineural fold, and then suture the geminal matrix back into the place. We have a condition where the nail bed loss is there with the bone exposed and the pulp laceration. We need not go for a shortening of the bone. We can go for a nail bed graft from the adjacent finger. I have taken it from the thumb here. This is the split graft from the thumb, which has to be kept over this pulp area covering the bone. The graft bed normally, the graft which you keep it as a free graft normally takes up This was a case of a finger pulp injury where you can see that the pulp is there, but there is a loss of nail bed. If there is associated injury to the other fingers, you can use a nail bed graft here, or from the toe also it can be taken, and then finally it will go on to heal like this. Now we have a crushed finger with the loss of pulp, no bone exposed. That means if the wound is less than 1.5 centimeters, you can go or allow the wound to heal by secondary intention by using semi-occlusive dressings. If the wound is more than 1.5 centimeter, it is ideally to go for a skin graft. And the best graft possible is to take a second layer palmar graft. So if you have an injury like that, you can go for a second layer palmar graft. The first layer of skin is flipped back, and you take the second layer dermal skin. You have a normal glabrous skin which is taken. So advantage is that there's no donor site morbidity, and then you have the same type of skin which is coming onto the pulp of the thumb where there was a lesion. There is a loss of tissue with no bone exposed. Now, if you have an amputation with the part available for a replantation or a revascularization, you can go for a debridement. In an initial stages, it is found that composite graft, where you take the entire part, defatten it, and then if you put it back, especially in children, less than 4 years, less than 4 hours, this was studied by Elliott, has shown that you have a good outcome by about 82%, even without repairing the vessels. The other option is to go for a revascularization or a replantation. Or if you think that the part is not having good amount of vessels, instead of going for a shortening or a flap, still you can go for a procedure which was described by Vijay Manske. It is not being published. And it is called as a graft reposition and flap technique, which we'll talk. So this was a case of a thumb injury. You can see that there was almost an injury at the base of the distal phalanx. We could find out the vessel on the volar side and the volar vein and the artery, and we tried to attempt a revascularization. This was in a case where he had multiple injuries for a traffic accident. You can see there is a deformity in the little finger. The ring finger was an avulsion injury, and it was not possible for a revascularization. And then there was an injury to the middle finger with the tip. So we went for a VY flap for this, which I'll talk about later. So the ring finger, we thought we will take up the finger parts. So we have separated the nail bed. We have taken the bone. We fixed the bone back and followed by putting the nail bed graft. And then the raw area is covered by a cross finger flap. So this was the technique described, which is called as a graft replacement and flap technique. You can see that the distal phalanx is stabilized with a small K-wire here, which is passed from the proximal to the distal part. So this was an outcome of a graft reposition flap technique in a thumb case. You can see that the donor area, the cross finger flap has been taken from the index finger dorsum. And the same tissue which was there was being used as a graft there. That is the hypopigmentation you see there. And then you can see the cross finger flap sitting there at the pulp. This was a case of bilateral thumb tip amputation, where you had taken the nail bed area there, and then we have used a VY flap, advancement flap, to cover that area, and that was the result. Now, if you have an amputated finger tip with the part not available for a replantation or a revascularization, then you decide what flap to be used based on the anatomy of the amputation. So you have a transverse amputation as per the Rosendale Classification or Allen's classification. We have a transverse amputation, which if it is a distal third, we have adequate amount of pulp tissues to be moved, can be moved distally. We go for a VY flap described by Attasoi. And if it is amputation in the proximal to the transverse amputation, we can go for an oblique triangular flap or a cross finger flap. We have a dorsal oblique amputations. Again, we can have adequate tissue on the volar side to do a VY flap. If it's a radial or an ulnar oblique amputations, the best flap which you have is a single digit flap, a homodigital artery flap, which is called as oblique triangular flap again. Or you can go for, if it is a volar amputation, we can go for a cross finger flap. And the thumb, we have the modified mobile flap or a cross finger flap. So I'll put it by example of how you go about doing all these things. So if you have a distal third amputation, we can take a V-shaped flap from the pulp side of this finger, The most important thing is that it normally doesn't cross the distal interphalangeal crease, the palmar digital crease. It doesn't move beyond that. It doesn't have a mobility beyond that. And then the amount of movement which you can get is about 1 centimeter. We cut along the skin and the dermal area and remove the fibrous bands. Its survival is based on the anastomosing vessels which are coming from the palmar digital arteries, which are coming from both sides. You can release it from the flap can be elevated from the flexor digitorum profundus tendon also. So that's the amount of mobility which you can get, and then it is sutured to the nail bed. So that is a VY flap, arthroscopic flap. There is another flap which is described where the flap is taken as a VY from the sides, which is called as a Cutlass flap, which I normally don't do. Because of the mobility is hardly about less than 1 centimeters. And normally you have a scar at the midline. So this is a healed VY flap. This was a case which was neglected initially. We thought the small wound is a small wound and then it can be allowed for a secondary healing. But it did not heal. He had a hypersensitivity at the fingertip and he had a small wound there. Went for a debridement. So this was amenable for a VY flap because it is a transverse wound and there is the amount of tissue. It is a distal third amputation and we have elevated the VY flap. That is a flap elevation and then how it has been sutured onto the nail bed. So oblique triangular flaps is indicated either for a transverse amputation or a radial or a volar oblique amputations. It was described by Venkateswamy, and our Indian plastic surgeon, who is quite famous for his contribution for different fields of hand surgery, our father of hand surgery in India, we can call, just like B.V. Joshi from Mumbai. And this is based on the radial or the ulnar digital arteries which are there, and it takes the nerve also with that. So it becomes a sensate neurohyaline flap. So it is mobilized based on the neurovascular hyaline of the radial or the ulnar digital side of the finger. And so this is a VY flap, the oblique triangular flap, which is being drawn to cover this sort of a transverse amputation. That is a neurovascular bundle, which is there, which is you can see. And it is elevated from all the surrounding tissue except for that neurovascular bundle there. And then it is mobilized to cover like that. It was a case of 2-finger amputation at the tip. And then we have taken a neurovascular hyaline flap, designed it, elevated. Both sides have been mobilized. And this was the outcome which you can see in the early postoperative period, where you are able to maintain the length. The nail bed is always there. And you have a sensate flap at the tip. It was a thumb amputation. You can elevate a neurohyaline flap from the tip if it is a tip area, or if it is a distal third amputation. And that was a phase in the early phase of healing. If you have an amputation of the thumb, which is much proximal, and if you want to retain the length of the phalanx without losing, and you see that there is a part of the nail bed which is there proximal to the lunula, I normally try to do a modified Moberg flap, which helps us to mobilize the tissue adequately based on the principal pollicis artery, which is entering from the ulnar side, and then mobilize it distally to cover. If you don't want to go for a flap from the adjacent finger, especially in a volar amputations, we cannot go for an oblique triangular or a VY flap. Then you have an option of taking a reverse digital artery flap based on the vascular channels. There are a lot of anastomosis between the two radial and ulnar arteries at various levels of the phalanx. So based on the distal anastomosis, we can take the paddle of skin island and leaving the nerve intact and then flip it around 180 degree. It was described by Kojima. And that is called as a Kojima's flap, where you take it distally up to the base of the middle phalanx area or to the neck of the middle phalanx area, where is the transverse level of anastomosis to the other side digital artery. And it is flipped across, and then it goes for have a good amount of tissue at the pulp. Cross finger flap it's a workhorse flap for any hand surgeon. The advantage is that it is very easy for us to do it. Disadvantage is that it requires a 2-stage procedure where you need to do the flap and then wait for 2 weeks and then have to divide the flap. So this was a case of an amputation where you went for a cross finger flap. Excuse me. So the disadvantage of one more thing is about putting a graft on the dorsum of the finger. So this was a case of a thumb amputation where you have taken a cross finger flap from the dorsum of the index finger, and the flap goes on to settle well. You can have multiple injuries in a hand, and then it at various levels. So it is all about for us to plan the flaps accordingly. So this case, he had injury to the thumb where the part was available. We have volar oblique amputations. We have a distal amputations of other fingers. So you do different types of flaps. You do a VY flap for one finger. You can do a cross finger flap for the other. And then you go on for a replantation of the thumb. And that is the outcome. To summarize, the most important thing about decision-making of a flap is the level of amputation and the anatomy of the amputation. And aim is always to preserve the length. You have a durable skin with good sensation and a good amount of aesthesis and cosmosis. Thank you very much.
Thank you very much, Latheesh. That was a fantastic talk, very comprehensive, and I think you have touched on all bases. Are there any questions that we have for Dr. Latheesh from the faculty? Or I was just checking the online stream. In the meantime, Dr. Ghodke, go ahead, please ask.
So we get this fingertip injuries anytime, and should we do you advise to do these flaps as an emergency or do it as a routine procedure? Next thing.
So that is the question. As a hand surgeon, I feel that if it comes in your reasonable period of time, I don't say that you have to take it up at the night, 12 o'clock or anything. But if you have a part available, and then if you are planning for a revascularization of a replantation, I think it is worth.
Replantation, yes, we can understand. Replantation has to be done. But if we are going for a cross finger or a VY or a
you can take it up just like a flexor tendon or extensor tendon injuries. Now, if you see in any book, it says that it is better for you to wait for experienced hand to treat. There is no problem in taking up in the next day where you are fresh and you're focused.
Can I just add something to this?
Sure.
It's more of a kind of a philosophical and kind of a practice.
You are always a philosophy man.
See, for a lot of patients, when they come to the hospital, a hand surgery is perhaps one of the hand injuries, one of the most gory and the most obvious kind of injury that a patient would have. And they're very concerned. The entire family is very anxious. So maybe at times it might make sense to be over and done with it at the earliest possible so that everyone is comforted. So maybe that might be one of the arguments. And of course, you want to prevent infections and so on and so forth.
Sure.
But at the same time, for those of us who are working in private institutions, perhaps, or in other sectors of healthcare, we all know that when people are taken up for surgery, there are certain emergency charges and other finance. The insurance, even if they have insurance, the insurance claims will not get processed immediately at that time. So we need to counsel. You cannot be dogmatic about okay, I'm going to do everything at the night, or I'm going to wait for the morning and then get the patient in. I think we need to counsel the patients very well. Sometimes you find that patients are so anxious, they say it doesn't matter, just get it done and be over with. And then we have to respect our patient, request or their will or what they want to get done. And there are people who will then understand and they say, okay, no problem, put a dressing on and then keep the hand elevated and come back in the morning and get the surgery done. So the pendulum may swing either ways. It all depends upon how much time we spend with our patients and counseling them and explaining to them. We know very well that a particular injury needs surgery early, and then we can help them and understand why it should be done early. And there are cases where you can wait. With children especially, the parents are always on tenterhooks, and I don't think it's a good idea to wait. Even for the simplest of injuries, even a laceration on the pulp, the parents should want that laceration to be treated at the earliest possible, and I think we should respect that. So just my 2 cents, you know, to kind of
correct, sir. So,
see
but,
in a different perspective.
only thing I want to add is, if you see the finger injuries, it falls into the two spectrum. One is in children and another is in elderly. So children, most of the time you need an anesthesia. So maybe
Correct.
that will decide about when we can take up. So children as such, I try to take up early in the morning because they'll be sleeping and NPO is adequate. If it is not an emergency, single injuries, because most of the children has got this door crush injuries. It's quite common. So elderly as such, we try to do it under local. But if there is comorbidities, always it is to work up and then not to rush. But as you said, I've been trained in Ganga. So what Rathabhavadi says is that you have asked only 2 questions, where and I am coming. That's all he says here to say. So we try to do it as an emergency basis.
He used to tell us you have 2 responses. Or 2
2 responses. What his plastic surgeon
vocal, the vocal reflex and the motor reflex. The vocal is I'm coming, and the motor is that you go. Great, thank you so much.
So one more question. So one of your case you showed just there was a thin rim of nail present. So till what region of nail injury you suggest that we can expect a nail growth again?
Yeah, that case which you have even a thin part of the nail, which is lunula, we can do a dorsal dermodesis.
Show on your nail.
Yeah, you can do a dorsal dermodesis normally, where you can cut a part of the dorsal skin and make the nail visible. That is one option which we do. That's called the dorsal dermodesis. We take a moon-shaped part of a skin, elliptical part of the skin, and then pull it back so that the nail is exposed. And if you have a very small part of the nail, it's better that you excise it completely, not to leave any geminal matrix to prevent any form of a cyst forming later on.
So what he's referring to is the procedure called as marsupialization.
Yeah, marsupialization. Yeah,
crescent-shaped zone from aponical fold here. But then you got to be very careful not to injure the germinal when you're excising the skin. And then you close it up so that you're exposed. So it's a more of a cosmetic kind of a thing where you expose, you are you're increasing the need, right? So great, thank you so much, Latheesh, for the fantastic.
One last, Abhijeet. Sorry. So normally in general orthopedic surgeons, what they do is whenever they have a nail bed in the fingertip injury along with a distal phalanx fracture, they pass in a needle. So what would you advise about that?
Yeah, that is one thing which is always we see. Now, I don't put a nail, any needle or hypodermic needle or a KY to stabilize the distal phalanx. If you adequately repair the nail bed, automatically the phalanx is coming back to position. Even if you see in the X-ray that is displaced. And if you are able to keep the nail plate back, that acts as a splint. And then you can give an external splint to immobilize it. Problem of putting hypodermic needle, one thing is that it doesn't allow the medullary, the circulation to happen. Another thing is the risk of infection, which you normally see. And if there is a vascular issue to the pulp, you're going to affect it more by passing the needle in multiple directions. And most of the needle is seen in the pulp rather than in the bone.
Great. So is that your last question, Ashok?
Okay. Thank you very much.
No. It's very important. What you asked is very important. I thank you for the question.
So because you might be seeing, Abhijeet, many patients they put a hypodermic needle and they just
hypodermic needle. Correct. I think as long as it is not doing any harm, everyone as a hand surgeon, maybe we might differ from doing it, but for a lot of orthopedic surgeons, it is a kind of a very commonly performed what you call as a soft tissue stabilization procedure, no harm in holding that part of the flap and then avoiding some taking lesser sutures. But just for the benefit of our orthopedic surgeon colleagues who might be viewing this webinar, there are a few takeaway points that I really want to stress upon before we move on to the next talk. One is that I think these are workhorse flaps, and everyone should learn and practice these flaps, because uh, every patient may not be able to come to a hand surgeon, or they may not have the resources or whatever. So every hand surgeon should know these flaps, such as the Viva Advanced and flap, maybe the cross finger flap, and these are flaps that will save the day for you and your patient. So one. Second thing is, never ever suture the flaps too tightly, or the flap margins tightly. Just take nice loose sutures. If you are in doubt, or if you don't know, and if you cannot refer the patient, always just pick up the phone and talk to your hand surgeon colleague and ask what needs to be done, and they will be more than happy to help you. So collaborate with someone who is more adept, and then start doing these flaps at your place. So with that, I thank you once again for being a part of this webinar, Latheesh, and all your wonderful, examples, and the talk was very nice. I would now like to invite Dr. Ashwin Lawande to please talk to us about the role of ultrasonography in hand and wrist surgery. And to the viewers again, I think after this talk, you will be surprised to know that ultrasonography has got such a wide application in hand and wrist surgery that at times it may render very expensive investigations redundant. So I request Dr. Lawande to please share his insights and teach us about the role of sonography in hand and wrist surgery. Thank you, Dr. Lawande.
Thank you, Abhijeet. Thank you, Ashok, for inviting me. I'm sharing my screen. There we go. Am I audible?
Yes, sir. Your slides are visible and you are audible. Thank you.
Perfect. So, how does ultrasound help us, and what are the indications when to do an ultrasound for hand pathologies? So, the commonest indications are for nerve entrapment, especially when the patient is having carpal tunnel syndrome, which is typically a clinical diagnosis, and where we do nerve conduction studies for seeing any functional status of the nerve, and the structural part is taken care of by the ultrasound. Then for tendon pathologies, for trauma-related injuries, inflammatory arthritis, lumps and bumps, and guidance to needle procedures. So first we'll start with imaging of the carpal tunnel and see how in ultrasound gives us the information about how the nerve gets compressed and what all we can give information. So for hand ultrasound, typically at the carpal tunnel level, we use this wide footprint probe, which has a better penetration and goes to a frequency of 14 megahertz. Then for finger and anything below the carpal tunnel up to the fingertip, we either use this 20 megahertz short footprint probe or this hockey stick probe, which is so useful in cases of flexion or extension deformities. So coming to the carpal tunnel, when we put the probe transverse on the carpal tunnel level, we definitely see the flexor retinaculum very well coming from the scaphoid and going to the pisiform there. And that's your median nerve, which appears, this is how it appears on sonography. It appears slightly darker as compared to the echogenic flexor tendons in the carpal tunnel. And the best part about ultrasound is you can move the particular structure and you can visualize which particular tendon is moving and how the nerve is moving relative to the flexors. So that's how, when we do a dynamic evaluation, you start from the pronator quadratus level, and that's how you see the median nerve going into the carpal tunnel between the flexor pollicis longus, and that's your long finger flexors. And then as you come distally, that's your FCR, which is outside the tunnel. This is the pisiform, the ulnar aspect, and that's your flexor retinaculum. This is your scaphoid, where the radial attachment of the flexor retinaculum is there, and that's your median nerve with the FPL and all long finger flexors. So this is how we image carpal tunnel from the proximal to the distal aspect, where we see the hook of hamate there and the tubercle of trapezium on the radial side. So when we turn the probe 90 degrees, we see this is how the median nerve goes through the carpal tunnel, sitting on the flexor digitorum superficialis and the profundus tendons. Now, when we see an abnormal case, this was the case of carpal tunnel syndrome, where the patient had significant paresthesia in the median nerve distribution. And also there was a little bit of flexion component, little bit of flexion restriction. So when you play this movie, you can see that the nerve is compressed in the mid and distal portion of the carpal tunnel, and that is here. And proximally, you can see the enlargement. The fascicles appear edematous at the site of enlargement there. And here it gets compressed. So typically we directly can see the evidence there where the nerve is compressed. So here the fascicles are compressed. Then as you go proximally, the nerve becomes edematous. So the fascicular echo pattern of the nerve, which is typically seen like cables, is not seen. This is the flexor tendon, which is nicely seen underneath it. And this hypoechoic or dark area, which you see between the FDS and FDP, is your inflamed synovium in the ulnar bursa. So that's how we see for any proximal enlargement of the nerve. We see for the distal compression. Then there are various criteria where we measure the cross-sectional areas of the nerve at the distal forearm level, that is just before the pronator quadratus starts, that is this level. Then where the nerve is enlarged at this level, then you measure the compression ratio at the distal tunnel level, and that's how we give you the information that yes, there is a severe compression, or there is a mild compression, or a moderate compression. And apart from that, we also give you the information that there is any flexor synovitis or no in the carpal tunnel. So for example, this is the same case where the cross-sectional area in the distal forearm is 6 millimeters square. Just proximal to the tunnel where it gets enlarged, because it's distally compressed, it's 32 millimeters square. So this particular difference, 6 millimeters and 32, is too big. So whenever the difference is more than 6 or 7 millimeters square, we consider as significant. And this is the enlargement. Then as you go distally, this particular transverse diameter to epidiameter ratio, we do it. And if it goes more than 3 or 4, then it's like an ancillary finding, which supports us in the direct findings of the nerve compression. Then most commonly we see that the nerve is bifid as it enters the tunnel. So at this time, what we do is we measure the cross-sectional area in the distal forearm there. And as just before it enters the tunnel, you can see that the nerve is bifid. So you measure both the trunks and you add the trunks. So this becomes 33 millimeters square as compared to the 7 millimeters square in the distal forearm. And then obviously look out for the compression ratio, which is significantly more, and the actual compression in the distal tunnel, which is the most commonly seen thing. And then obviously the entire tunnel is opened and the nerve can breathe and slowly recovers. So this was a middle-aged man with carpal tunnel symptoms, and that was the median nerve just proximal to the tunnel. Within the tunnel, it is getting slightly compressed there, and you can see that there is a space-occupying lesion there. So this is an anechoic lesion, something like a cyst, which we call on sonography, clear fluid contents or clear gel-like contents, and this was a ganglion in the carpal tunnel, which was compressing. So this is your FPL, that's your compressed median nerve, and these are your long finger flexors in the distal portion of the tunnel. And that's how you see it in the long axis. So the root of the ganglion, if you see on this video, you can actually see that's your flexor retinaculum, your median nerve, that's your FPL, because that's the radial portion of the tunnel. And this is your ganglion between the FPL and the long finger flexors. And as you turn your probe at 90 degrees, you can see that the stalk of the ganglion is coming from the radiocarpal joint. That's the stalk coming from the radiocarpal. So it's a fairly long ganglion and at an unusual site. Normally ganglions commonly are seen on the dorsal aspect of the wrist. So that's how it was planned, given a roadmap kind of to the surgeon to do the surgery. That's the reflection, and you can see the ganglion there. And that's the stalk of the ganglion coming from the radiocarpal joint, and that's the retrieval of the entire ganglion. Another very challenging case which I did was this patient had repeated carpal tunnel symptoms in the right hand. So he was operated for for the carpal tunnel in the right hand in 2001. Then again in the right hand in 2018, and again he started developing symptoms, and this was sometime in 2019, 2020. And what you see here is that there is severe sensory motor slowing across the wrist with a partial conduction block in motor fibers at the wrist. So again, ultrasound was asked for, and this is in the short axis, which you see in the distal forearm. This is your median nerve. This is your FDS, FDP. That's your pronator quadratus, and that's your FPL. So your median nerve is normal here, 9 millimeters square. Just proximal to the tunnel, it's significantly enlarged. It's almost 27 millimeters square. And then you see, turn your angle probe at 90 degrees, and you can see the long axis of the median nerve. You definitely see a lot of contoural bulge and compression. This is the normal median nerve from the distal forearm. This is the level of the wrist joint. So this is your FDS, FDP, and you can see this is the first bulge. Then you see a slight compression there. Then you see the second bulge, and then you see even severe compression there. So that's why this patient was having repeat symptoms, and probably it was a thick fibrotic band here which was compressing the nerve, and a thinner band which was here which was compressing. So predominantly scar tissue. So again, surgically it was opened, and then you can actually see that that's the fibrotic band there, and the proximal proximal band there also. So with this, we could kind of correlate our surgery and the ultrasound findings that these were the two areas of compression. This distal one was severe, which is located here because of the thick fibrotic band, and the proximal one is at this level, which is here, and that's the proximal enlargement where the cross-sectional area came significantly more. This was a young surgeon with a little finger injury, and basically the patient was not able to flex the finger at the DIP joint, so kind of suspecting some kind of flexure injury, predominantly an FDP, because the flexion at the MCP and the PIP was quite okay. So when you put the probe on the long axis of the finger, what you see here is you don't see the tendon tissue at all. You just see the empty sheath. The volar plate is intact, but you definitely see that there is some kind of loss of bone here. So this is like a zone 1 injury where the FDP has avulsed from the insertion, and you don't see the FDP at the level of the middle phalanx shaft. Then you kind of, patient is not able to move, so you do a passive flexion extension of the distal phalanx, and you can see that only the volar plate is moving and the empty sheath is moving, but there is hardly any movement proximally. Then you keep the probe at the PIP joint level and see for the FDS movement. So this is your FDS tendon, which is intact, and you can see the lateral slips going posteriorly there and inserting on the middle phalanx. So even your FDS is intact, your PIP volar plate is fine. And then you can, then you come even more proximally, you see that the FDS is intact, but your FDP has kind of retracted at this level with the bony fragment. So that avulsed bony fragment has retracted at this mid shaft of the proximal phalanx level. So when we report, we definitely tell that yes, it's a zone 1 injury, and there is avulsion of the FDP from the insertion along with the bony fragment, and that bony fragment along with the retracted stump is lying at the mid shaft of the proximal phalanx. We also give the distance from the 1.1 centimeter distal to the MCP joint. And then we check out for the retraction of the FDP in the palm, because that is another place where the tendon becomes wavy and gets retracted. And sometimes we do find even tears in that retracted portion, which is difficult to detect on ultrasound. But when you operate, you can actually see it with the naked eye sometimes if it's a long-standing injury. So if you see here, that's the retracted FDP with the bony fragment. Then it is pulled distally and finally hooked onto its insertion. Then we have a case where there is a sharp object injury to the left thumb distal to the MCP joint, and the patient has lost his flexion at the IP joint, which is your FPL action. So what you see here is a distal FPL stump there. That's the IP joint and the volar plate. You don't see any FPL tendon tissue proximally there. And if I trace it transverse through the thenar eminence, I don't see any FPL tissue. But as I go into the palm, distal forearm, that's the FCR. You see a retracted FPL underneath the FCR there. So it is a zone 2 injury, but we are not seeing any retraction locally. It's a retraction all the way into the palm. So with the help of ultrasound, we can, apart from telling you that it's a zone 1, zone 2, or a zone 3 injury, we can also tell you the amount of retraction the proximal stump has taken. And plus, the examination does not end there. We also have to see for the palmaris longus tendon with the ultrasound. If with this particular maneuver, you are not able to see the palmaris longus physically. Then this was a sudden loss of flexion in post-repair in the index finger. During physiotherapy, the patient suddenly felt a pop and he was not able to do those flexion movements, which he had kind of obtained after a good physiotherapy. So what you see here is that's the FDP. And at the PIP joint level, the sutures have given way, and you can see that the distal stump is moving when you passively move the fingertip, but the proximal stump has retracted all the way back into the palm at the just proximal to the MCP joint. So this is just your FDS which is moving, but your FDP has kind of retracted here. You can see the retracted FDP in the palm. So that's how a tendon appears wavy, and that's your FDS, which is still intact and doing normal movements. Then we come to extensor tendon injuries. This was a this was a cricket ball injury where you can actually see that the central band is kind of inserting at the base of the middle phalanx, but the extension movements, it's painful for the patient. And here you can actually see with dynamic voluntary evaluation that yes, there is some kind of avulsion with the bony fragment there at the central band insertion, but still predominantly the central band majority fibers are intact, even though there is a partial tear. So this we give as a partial tear, and then it all depends upon how bad is that tear to be repaired. So most of the time these partial tears are treated conservatively. But when you see such a case where there is a complete sharp object injury and there is a complete loss of flexion, extension movement at the PIP joint, this is the extensor tendon, the central band coming here, and then at this level, just proximal to the PIP, you don't see any continuity at all, and the distal stump is located at the insertion. So this was a complete transaction injury of the central band, and this is usually because of the sharp objects like knife injuries or glass injuries, which usually when these bands get cut. Then after tendon trauma, we come to tenosynovitis, and decurvance is one of the commonest tenosynovitis which we occur in our day-to-day practice. So typically, this is a normal wrist where you can see the APL and EPB tendons underneath the thin extensor retinaculum along the distal radius in the long axis. But whenever this black line which you see, which is the extensor retinaculum, whenever it becomes thick, you can see the black line has become so thick now. So this is thickness of the retinaculum, which is further continuing as thickened synovium in the APL and EPB sheath. And you can see the distal fluid and the synovial thickening in the distal APL and EPB sheath. Plus, you can see that because it's a long-standing thing, the tendons are also enlarged as compared to the normal. And the most important thing is they are in the single compartment. You can see the multiple slips of APL and the single slip of EPB there. And then when you do your Finkelstein's test, it becomes positive because there is significant pain here. And you can see the impingement against the thickened retinaculum. That's why this particular movement or your radial ulnar deviation gets affected. Sometimes the patients do come with decurvance tenosynovitis, but with a selective EPB compartment involvement when you see a thickened retinaculum around the EPB, but the APL is spared. So that is the time when ultrasound can really help in telling you that yes, only the EPB compartment is involved. And there you can see the EPB, which is thick, and that's a thickened retinaculum. And that's how the tendon thickness increases as it repeatedly rubs and undergoes inflammation. As compared to that, the APL in the same but a separate compartment, you can see that it's normal in caliber and you don't see any synovitis around it. So this is abnormal side, that's the normal side. So on the normal side, again, you can see that EPB is in a separate compartment, but you can see that it's normal. The retinaculum is also normal. That's the APL. And you can, here you see the difference, how it is selectively involved. Then other things, other pathologies which you commonly see are your trigger fingers. So when trigger fingers, on ultrasound, you see all the annular pulleys very well, but the most important annular pulley, which is frequently diseased in a day-to-day practice, is the A1 pulley. So normal thickness is 0.4 or 0.3 millimeters, but when it becomes thick, these tendons, flexors underneath it, get impinged. So that's in the short axis, that's in the long axis. So when you do your flexion extension movements, it gets impinged, the tendon sheath becomes irritated distally, and you can see the fluid in the flexor sheath all the way up to the FDP insertion. So when you play a movie here, that's a thickened pulley, and the FDS is kind of not moving properly because it's getting impinged there, and you can observe and document the click, whereas the FDP is moving smoothly. So in such cases, if it's a minor thing and if the patient doesn't want a surgery, then we do definitely sometimes give ultrasound guided local steroid injections in the tendon sheath. And if the patient is fine for the surgery or can straight away wants to go ahead with the surgery, then usually it's operated regularly. Then sometimes the patient is coming with a swollen finger, he's not able to flex the finger completely, and you can see that the entire flexor sheath, this is the FDS and that's the FDP. So at the MCP joint, you see both the tendons together, one on top of each other. And at the TIP joint, you see the FDP, which is superficial, and the FDS lateral slips are underneath it. And then distal to that, you only see the FDP tendon. So here you can see this thick hypoechoic tissue, which is there. That's all the inflamed synovium all the way up to the FDP insertion. And this was a case of rheumatoid arthritis where you can actually see synovial inflammatory synovitis in the MCP joint and also in the flexor sheath. Then sometimes we do see swellings along the dorsal aspect of the wrist, which you have to differentiate whether it's a tenosynovitis of the extensor compartment 4 or it's a ganglion. And this, when you keep the probe on the dorsal aspect of the wrist, you see the extensor digitorum communis tendons and the thickened synovium around it. That's the tendons in the long axis with the synovium around it. And once the synovectomy is done, the patient is free of his pain and the swelling. But sometimes these swellings can also turn out to be ganglions, which are like these. And very commonly, we do ultrasound guided aspirations by giving local anesthetic and putting in an 18 gauge needle, aspirating the ganglion, fenestrating the deeper portion of the ganglion, and then injecting a little bit of 40 milligram of Kenacort within the empty ganglion cavity and a little bit into the radiocarpal joint. So this helps temporarily, and most of the times you have seen that these ganglions usually don't come back, and if they come back, then the patient is ready for a surgical excision. Let's see this in a very interesting case. This was a middle-aged lady with painless, gradually increasing lump in the left palm, and she doesn't have any motor sensory deficit. What you see here is the lump is in the left thenar eminence there, and it's also protruding between the second and the third or the third web space here, this along the dorsal aspect. On ultrasound, we see that this mass is located in the thenar, in between the thenar group of muscles there. It is elevating all the long finger flexors, and then it is going in between the second and the third metacarpals dorsally, elevating the dorsal interosseous. So that is in the thenar eminence. You can see it is lifting up the radial digital nerve to the index finger and the ulnar digital nerve to the thumb. And it's also kind of separating the two heads of adductor pollicis. That's on the dorsal aspect. That's why you see the labeled first dorsal interosseous. And it's lifting up the dorsal interosseous between the third and the fourth metacarpals, and it's going up on the dorsal aspect. So once that's the normal dorsal interosseous in the second intermetacarpal space. So when you give a roadmap like this by drawing a diagram to the surgeon, then it helps in planning the surgery that yes, the incision has to be taken from the volar aspect, taking care of these two digital nerves, and then entire thing can be enucleated. So that's how it was planned. Thank you, Patankar sir, for giving me these post-operative images, and that's how it was enucleated. Next is this middle-aged doc who had a painless hard lump in the left thumb. And scanning the left thumb, this is along the short axis of the thumb. And when you scan along the short axis, that's your FPL. This is your nerve, that's your artery on the radial side, neurovascular bundle on the ulnar side, and that's your mass. So that is the nerve which is going on top of the tumor, and that's the artery which is going along the side of the tumor. So both are splayed. Then the tendon sheath is not involved. That's the pulley, that's the FPL, the pulley, and then the mass. So most commonly when you see this hypoechoic solid masses which show vascularity on Doppler and also cause some impression on the bone, cortical scalloping, these are commonly giant cell tumors, and they means as radiologists we have to give you relationships with the surrounding structure so that it provides a nice roadmap for surgery. So that was the radial digital artery which was supplying it to multiple feeders, and this is the diagram given. That's the neurovascular bundle on the radial aspect and the FPL sheath. FPL tendon per se is not involved. The bone is not involved. It's not going into any joint. And then first of all, the neurovascular bundle is kind of separated. Then the mass is enucleated. And finally, the closure. Then a young girl comes with painless soft swelling in the left middle finger. And what you see here is that the lump is there along the volar and ulnar aspect of the middle finger. That's the whole lump. That's the lesion. It looks solid. That's in the short axis. And that's a draining vein which is coming from the cranial aspect of the lesion going into the palm. And it is compressible. So first thing which comes to our mind is that it's a kind of a vascular malformation, a slow flow venous vascular malformation, that's a draining vein. I'm coming proximal to distal in the short axis. That's the mass. And you can see the ulnar neurovascular bundle going on the undersurface. That's the nerve. That's the artery. It's not involving the tendons because that's the tendons and the flexor sheath. That's the draining vein. And that's how the ulnar digital artery going on the undersurface is giving feeders. Compression and release, you can see that how the lesion is compressible and filling up with slow flow color, so typical of a hemangioma or a slow flow venous malformation. So a diagram of this kind is given so that you're able to appreciate that, yes, it is well defined, it is well encapsulated, it is excisable, and these are the relationships. Then we come to severe pain in the ulnar nail bed, which is again a very agonizing pain for the patient. So that's suspicion of a kind of a glomus tumor. So that's the nail bed, which you can see with the 20 megahertz probe. That's the DIP joint, the nail bed. And as this is the radial side, but as you come towards the ulnar side, you can see that there's a lesion here around 7 millimeters distal to the the DIP, and then you put vascularity, and this is the nail bed vascularity, which is normal. That's on the radial side of the nail bed. Now you come to the ulnar side, and you can actually see that this is the lesion with intense flow within the lesion. So typically glomus tumors are vascular, and this is how it's measured. That's around 3 by 2 millimeters. That's the glomus. That's the nail bed, and that's the distal phalanx in the short axis. And giving you a location that it's 6 millimeters or 7 millimeters distal to the DIP, and it's a glomus. And I thank Parag for giving me this post-operative images. The nail bed is nicely opened, it's beautifully dissected, and it's resected. Then last few cases, we also do this kind of, we also give this kind of information where patients come with syndactyles, the fingers have to be separated. So apart from the flexor and the extensor tendon apparatus, we also give this kind of circulation roadmap where, it's important to tell that which intermetacarpal arteries are prominent and which are dominant in which finger, and whether they are going on either sides of the digits. So that helps in separation. And that is one such case which was successfully separated. I thank Warrior sir for giving me this images pre-op and post-op. And that's how we had planned it. And this is how it was kind of. Okay. So with this, ultrasound can give so much information and even much more than other radiology modalities that when we need to see soft tissue structures, we can really take help of dynamic evaluation and give a good amount of information. And most of the times, the information what we get on ultrasound is much more than what we get on any other cross-sectional imaging modalities, except for bone and marrow information. So with the correct equipment and the right frequency probe, most important thing is knowing your anatomy. I think that helps us in giving you a good, accurate roadmap or a Google map, which is so helpful. So honestly, I have learned a lot from my operative feedbacks, and doing a specialized ultrasound like this with the thought process of a surgeon makes the scan very motivating and productive. I thank you for your attention.
Thank you so much, Dr. Lawande. Those are a very fascinating talk and very, very intriguing, very informative, and it just kind of opens up so many vistas to the possibilities of application of ultrasound and diagnosing so many different conditions in hand and the rest. In fact, going one step further, there's a very dear friend of mine from France, Olivier Maris, who is now pioneering. That makes it very interesting because it eliminates radiation exposure, it eliminates expensive arthroscopy equipment, and is very, very nice, especially for conditions like carpal release or lancet release, ganglion excision. Are there any questions? I was also looking at the online live feed. There aren't any questions on the online live feed yet, but from amongst the faculty, I had one very quick question for you, Dr. Lawande. I'm interested in knowing one very nice thing that I noticed on your presentation was all the videos and the images that you were showing had a line diagram of the hand with the orientation of the probe. So what is it exactly that we are looking at? The longitudinal orientation, that's very, very beautiful. I can't remember of any other sonography report that I have seen with such wonderful details. It orients, the surgeon to the image, especially to the uninitiated surgeon for that matter. And I'm going to suggest this to my radiology colleagues also, to put up that little schematic diagram with the probe position highlighting which direction we are investigating and looking at these structures. But very nice presentation. I thoroughly enjoyed it. If there are any burning questions, I request you all to put them up in the chat box, and if there are any questions, we can take them up towards the end of the session, perhaps. Sure. I'm very grateful to you for finding time on a Sunday. I now request Dr. Gori, our next speaker. Thank you very much.
Thank you. So, Dr. Ashwin's figures are very, very famous. I mean, we thoroughly enjoy those. Thank you, Dr. Ashwin.
Thank you.
So we move on further. I request Dr. Kiran Ladkat. He will be speaking on flexor tendon injuries. Kiran?
Dr. Ghodke, I request you to also please, it slipped my mind, but could you please introduce Dr. Ladkat as well as Dr. Ashwin from the previous talk? I'm terribly sorry to have missed out on that. Just a brief introduction, please. Thank you.
Dr. Ashwin is a radiologist. He is practicing in Dadar and he is a specialist in hand sonography. I had a question to Dr. Ashwin. Have you
Yeah.
ever done an intraoperative sonography?
Intraoperative, unfortunately, since I am working in a private clinic, intraoperative problem is that intraoperative ultrasound machine should be there in the theater. And the most important thing is that small footprint, very high frequency probe should be there.
Because we heard a couple of times from Dr. Warrior that
Yes,
he
yes.
had asked for an intraoperative sonography. So it is really new for us.
Yeah, see,
Anyway, thanks.
thank you. Thank you.
Yeah. So our next speaker is Dr. Kiran Ladkat. He is a hand surgeon from Mumbai, and he will be talking on flexor tendon injuries. Dr. Kiran.
Dr. Godke, thank you very much. I'm audible and
Yes,
as well.
Yeah, both. Great.
Is there any echo because of the speaker here?
No.
No, right? Is it okay?
Yeah. Okay.
Yeah. At the outset, I'd like to thank West Zone of the IOA team, Dr. Godke, Dr. Wahegaonkar, for giving me the opportunity. I'd like to sharing some thoughts and some case scenarios in the flexor tendon injury for the benefit of the audience, which includes hand surgeons and orthopedic surgeons as well. Good evening, everyone. In continuation to talk by Dr. Lawande, with whom we have worked, and his ultrasound skills have helped us a lot. And this flexor tendon injury and then the following extensor tendon injury is one arena where ultrasound will help any surgeon quite a lot, which he has shown in his talks. To give an overview, few slides of anatomy, then the clinical assessment and the diagnosis, surgical considerations in flexor tendon injury repairs, some case scenarios which we have tackled. Following is the rehabilitation protocol and the secondary reconstruction of neglected or delayed tendon injuries, what we see. Coming to this famous line diagram of Vardhan's zones of flexor tendons. Zone 1 is up to the neck of the middle phalanx. From then proximally up to the distal palmar crease is zone 2, which is famously called as no man's land, and these two zones are the critical areas in flexor tendon injuries. Zone 3, 4, 5, where the flexor tendon injuries, if unfortunately happen, they have reasonably favorable outcome. But not to forget, it will involve neurovascular injury also, which you need to take into account. Briefly onto the anatomy, this is how the sagittal section of the finger looks. The flexor digitorum superficialis and the profundus. The FDS inserts onto the base of the middle phalanx in a fan manner. They decussate at the level of the shaft of the proximal phalanx, wherein the deep flexor digitorum profundus tendons comes in. This level is called as the Camper's chiasma, and it goes on to insert onto the base of the distal phalanx. These areas you can see as those vincula, which gives nutritional supply to the flexors superficialis and the profundus both. L means vincula longa and B means vincula breva, and S and P is superficialis and profundus. Now this is again a diagram of the blood supply of the flexors of the in the finger. Common digital artery divides into the radial and ulnar digital artery of subsequent adjacent digits. Now they give branches to the vincula, and then on the sagittal sides they give transverse digital arteries which supply at the level of the proximal, middle, and distal phalanx, and then they ramify to supply to the pulp. Now simultaneously, if you see the pulley structures, the A stands for annular pulley, C stands for cruciate pulley. A2 and A4 are the cruciate annular pulleys, whereas which are sitting at the level of the proximal phalanx is A2, proximal middle phalanx is A4. A1, A3, A5 sit at the level of the respective joints, that's MCP, PIP, and DIP. In between A2 and A3, there is a cruciate pulley. In between A3 and A4, there is second, and A4 and A5, there is third cruciate pulley, which gives some support to the annular pulleys. Coming to the brief clinical assessment, this picture I have taken from Green's textbook of hand surgery. Now on the left, you can see the flexor digitorum superficial action, wherein the PIP joint is flexed, and as you isolate or stabilize the PIP joint and then ask the patient to flex the DIP joint, individual action of flexor digitorum profundus comes into place. So this is how you should clinically assess or isolate FDS and FDP actions. Subsequently, if you have to check other fingers like middle finger, you have to stabilize index, ring, and little to isolate the middle finger different actions of FDS and FDP. For the thumb, you have to stabilize the MCP joint to check the action of the flexor pollicis longus onto the IP joint of the thumb. Now these are the various exploration scar marks which you can see. Now the lines drawn in a dotted manner are the possible wounds which you can get in the hand injuries, and these injuries can be extended in these manners proximally and distally. The classical Brunner's incision which is described is drawn in the little finger, whereas in the ring finger, if the injury is onto the MCP crease, it can be extended in the axial manner and in the palm on the palmar crease, so that you have a better flap coverage without any terminal necrosis of the flaps. Coming to the different repair patterns, these are the different tendon repair patterns which are described in textbooks. Commonly are the strict line and the four strand. We usually advocate or carry out modified Kessler's 4-strand core repair, and then followed by epitendinous repair with a 5-0 or 6-0 polypropylene, that's proline. Partial tendon lacerations also need to be considered, wherein there will be pain on active flexion. The flexion attitude of the finger will remain, but there will be pain. It can progress to late tendon ruptures and aggravating the tendon entrapment and or triggering. If it is more than 50%, you definitely consider to repair that, because it can lead to complete rupture. If it is less than 50%, debride the or ragged edges or repair. That's at the surgeon's discretion. Now coming to certain case scenarios where the zone 1 and zone 2 are the most critical areas to look into. This was a middle-aged lady which sustained injury to the middle finger when she tried to catch the handlebar on the bus. When the bus suddenly gave a jerk, she sustained a snap in the middle fingertip. As you can see, the other fingers have a flex attitude with the fingertips, whereas the DIP is in an extended position, which you can see in these images. Theoretically, you can see the Latheesh classification, the 3 types. In type 1, the FDP tendon has avulsed down into the palm, proximal to the MCP joint. In type 2, it is lying into the synovial sheath, and in type 3, it is still at the distal edge of the A4 pulley, and it is usually along with a bony fragment. That's where it gets stuck at the distal edge of the A4 pulley. Type 3 is a commonly found Latheesh classification. In the right side image, you can see different areas of repair of this. You can pull out the tendon with the Baker stitch, and then this stitch with straight Keith needles drilled into the distal phalanx, keeping in mind or taking care of this germinal matrix. You should either come proximal to the germinal matrix to avoid nail bed injury, or distal beyond the lunula into the sterile matrix to avoid any nail bed issues. And a pull-out button is wrapped around, and the tendon healing is supported, and subsequently the range of motion. The line diagram below shows you the Baker stitch pattern, which you can consider for the tendon repair. This is that case scenario which I described. This is the fragment, the distal phalanx fragment, which was got trapped at the level of the A4 pulley. As when we opened, we could see the void, and this is the fragment which is seen along with the FDP attachment. In this diagram, this is the Synthes E-Pain or pen drive. It is called. It is a very good RPM. If it is available in the operating room, it's of the most useful tool you can have in the hand surgery. But if you don't have, you can consider to have low torque or low RPM drills, which are crucial to prevent any toggling effect on the fingertips. This is the closure what we get of the flap and a pull-out button seen on the dorsal side. This is the fracture fixation. The joint was congruous, and this particular, although there was some gap, but still it went on to heal nicely. And this was at 6 weeks healing fracture, and this is the moment what she got at the 6 months time. She's able to carry out her day-to-day routine. She's moving her fingers very well, and she can make a grip also very well now. As in, it was a gratifying result for her, and she's carrying out day-to-day routine well. A similar case scenario, she's a company secretary by profession. Her ring finger is lying straight. It has hardly any flexion, and the good bony chunk, which you can see it on the X-rays here. Again, the same void because of the fracture. Now these two stitches I have taken into the FDP on the adjacent sides for them to pass on the dorsal aspect, which I described in the line diagram, and the pull-out button on the dorsal end with the straight needles. This is how the fracture was fixed with 1.3 mm screw. These two bony fragments were lying exactly here and not irritating the pulp. That's why we left it alone. This is at 2 weeks where the wound is healed and the pull-out button is seen. Coming to zone 2 injuries, which are the most crucial because of the very tiny tunnels between A1 and A4 pulley. Now these are certain considerations you should consider for these zone 2 injuries. Core sutures and epitendinous sutures. Core sutures with either 3-0 non-absorbable. Ethylon or Prolene are the brands which are non-absorbable stitch materials on a round body needles, and epitendinous sutures with either 5-0 or 6-0 Prolenes. Now, taking it in a locking loop is better because that gives a good strength for the repair as compared to the grasping stitch. Gap formation can lead to gliding resistance. So that's why minimizing the gap and adjusting the tensions is very important during this locking loop. Now it comes sometimes the suture materials, or some surgeons do prefer to use loop sutures. So adjusting the tension during the repair with the loop suture is very critical. Biological considerations in the form of the healing phase, the immediate inflammatory phase, the intermediate healing phase, and the remodeling phase. So these immediate inflammatory and the remodeling phase is very crucial to consider, because that is when, and that is around say up to 2 weeks, that is when the repair sites giving way or re-rupturing again is very common. So those first 2 weeks are very crucial, where you should have a very good supervised rehab. Post-operative passive motion rehabilitation comes into play over there with the help of good therapists. With future concepts of fibrin glue and vitamin C at the repair sites. Now, fibrin glue theoretically adds to gliding resistance, and it is additionally supporting the repair. But it is still in a theoretical phase, and as a surgeon, we are not endorsing it because there are issues of adhesion formation also. Vitamin C has some supportive role in cadaver models, which is yet to be seen clinically. When you consider or when you carry out the repair of the injured tendons, intrasynovial flexor tendons, This is how the arc of the fingers should be rested in, and that is what you should take care. This line diagram is very important to adjust the tension accordingly. So one case scenario where this young boy, 10th grade student, fell down on a sharp glass surface adjacent to the road, and he sustained the injury. To note, he had a hyperlaxity to the fingers. That's why he had Swannick attitude in the other fingers. But you can distinctly see the extension attitude of this finger, ring finger. Now, one important finding to note is the position of the finger during at the time of the injury. If the fingers are flexed during the sharp cut injury, then when they extend, the torn ends or the separated ends going apart and creating a gap is significant. Whereas in an extended finger, if the injury is happening, the torn ends, you can find it exactly at the place where they're injured. So that makes your understanding of the injury also easy. So that you need to consider about, right? Now on the right side, this injury I had taken into consideration. I had raised the flaps proximally and distally. As you can see, this was as soon as it was explored. You can see the neurovascular bundles on the sides. He had some hypoesthesia, but the nerve was intact. The sensory symptoms resolved gradually. As we opened the A1 pulley and the A2 pulley proximal edge, we could see the torn ends here. We can see the two FDS ends, and this is the FDP. The FDP distal end is retracted here, retracted distally. Now we can see in this video, as I passively flex this finger, we can see the tendon ends coming into the injury zone, both FDS and FDP. You can see it here. See the tendon ends coming up into the wound here, right? And this much flexion is required to get into the place. Now, as you see here again, this is at the time of the repair. As I repaired the FDP, it's going through the A2 pulley, and this is the resting tension. The rehab part is very crucial in this zone 1 and zone 2 injuries. A dorsal blocking splint with wrist in around 20 to 30 degrees of flexion, MCP in around 50 to 60 degrees of flexion, and IP joints neutral. There will be bands at the level of the first web space and at the level of the IP joints. Passive motions of the finger flexion, and then gradually patient extending to the blocking splint, and place and hold. These are the key exercises one should execute for first 2 to 3 weeks. 3 weeks is a good time when this splint can gradually go away, and then subsequently you can think of giving a hinge in the splint. If that is not available, this thermoplastic splint can be molded by the orthotist, and this particular wrist flexion can be gradually extended to get the tenodesis effect back. You can see here with the hinge, patient is doing tenodesis. So if you can see it here, as the wrist goes into flexion, the fingers extend. As the wrist comes or wrist extends, the fingers curl and they flex. This is how the tendon gliding also can be ensued, and place and hold again is very crucial. Beyond 3 weeks, then gradual, once the tendon is consolidating, then you can start with active extension. At 6 weeks, you can leave aside the splint and then gradually concentrate on the full range of motion. And then subsequently, if flexion contraction ensues, with the static and the dynamic hip splints, you can stretch out those flexion contractures. By around say 4 to 6 months, patient can go on to his routine activities, his or her routine activities. Now, this particular case had a complication. This is the same patient whom I had repaired primarily, but probably he had heard some snap in that 2 to 3 week period, and then he came late because of his exams. He had re-ruptured his repaired tendons. Now, ultrasound came to our use. Unfortunately, I don't have the report, but ultrasoundologist here in our hospital had given us a clear report saying the FDP is completely torn. FDS partial slips are there, but not so healthy. Now you can see here the FDP torn ends, and with the fibrotic changes since patient came late because of his personal reasons. We had to do it primary tendon grafting because the tissues were still supple. We harvested a palmaris longus graft and we reconstructed the FDP, FDS. We left it alone, and this was a drain tube drain we had kept. This is the arc which I had presented in an earlier image. This week we could get it to the finger in appropriate tension, and this is the function we could get it at 6 months. With which he has through WhatsApp he had sent me the video. He is pursuing his MBA in this National Defense Academy courses. Now note a difference. He's not actively able to flex the PIP joint, but DIP flexion is there. That's because we didn't prepare the FDS and we had to graft only the FDP. But he hardly has any functional deficit because of it. Now, one point to consider here is whether to repair both FDS and FDP in zone 2. That depends on the injury. That depends on the tissue structure or the physiology there. If you can repair both, you can get individual joint functions. But if the tissues are very tight or there is a lot of contamination there, and you feel there is a lot of overstuffing, then you can repair only FDP and one slip of FDS. Other slip can be taken. Late presentations of zone 2, you can see this this lady police officer, a sharp cut injury which was primarily closed. One point here I would like to mention, most important point is not to neglect these injuries just as superficial ones. These injuries need exploration. The treating physician earlier and the patient, they neglected this injury, they just closed it primarily. And this is how she came up with at around 1.5 to 2 months with inability to flex the DIP joint. Interestingly, now ultrasound came to our use here. The ultrasonologist gave us a good idea, the coiled FDP here, and this is the gap, and this was a stump. And if you see very nicely, as sonologist mentioned, we could see the coiled FDP coming out in the palm. Now, since this particular tunnel, or rather the tissues were relatively supple, we decided to do a primary tendon grafting, and we could get the tunnel sheath. This is the flexor digitorum profundus tendon. This is a palmaris tendon graft. This is the coiled part which we excised. And this is how we could pass on the infant feeding tube through the tunnel, and it was a smooth gliding, so there were no adhesions there. This was the excised flexor digitorum profundus part, which was fibrous. This is the tendon end which we could see, and this is the follow-up at 6 weeks. We can see it here. The scars have well healed. There is flexion contracture, but she is getting the flexion back at the level of the DIP. This was with the button. Sorry, just a minute. So as you see her, FPL injuries, flexor pollicis longus injuries in zone 2 are notorious ones. It poses a unique difficulty because of the proximal tendon retraction below the thinner eminence or even at the level of the flexor retinaculum. Some proximal to the distal edge of the thinner musculature, you need to have a separate incision through carpal tunnel or in the distal forearm. Infant feeding tube or similar silicone tube for retrieval will be crucial and will be important here to help. This was a shipment onboard injury and repaired at some overseas hospital, and this was the scar he came up with. Ultrasound giving us idea, and he had marked a failed tendon, the distal end, and the proximal end was lying here. Although it was sutured back, but it gave way. Now, as you can see here, you could see a suture end here, and the proximal suture end was here, lying here. Now we harvested a palmaris longus tendon graft. This was a suture end. We retrieved it through the proximal wound. This is the gap, and this is the proximal. This is the palmar longus tendon graft we harvested. We repaired primary palmar longus tendon graft to the distal end, and through this tunnel, you can see our hemostat coming in through the wound, through the tunnel here. We retrieved the palmar longus tendon graft in the proximal wound, and we saw we could on table we assessed the gliding of the palmar longus tendon graft and the integrity of the distal repair site, which was intact, and adjusting the tension of the palmar longus tendon graft, we repaired it at the proximal edge with a pulver tuft weave. This is the function he got at the level of at 3 months. Individual IP joint flexion he could get, and good MCP flexion as well. This is what he could show us at the level at 3 months. Good strength in the repaired palmar longus tendon graft with the movement, and full movement of the hand and the wrist. This was at 1 year. I asked him to demonstrate tenodesis effect. And this is how he showed us at 1 year, and he's gone back to his full function on board. So again, the rehab part which I described holds true for all the fingers and the thumb also. Initial passive mobilization with good supervised therapy, and then subsequently stretching it out will be crucial here. As far as the tendon reconstruction or for the delayed or late presentations is concerned, this is the reconstruction ladder, wherein you should consider either do nothing, tenolysis when the repair is intact, tendon transfers of the adjacent flexors to the recipient tendon, primary or to two-stage tendon graft with Syrian. This is where Dr. Lawande came to our help in one of the cases, wherein he showed us, or he guided, that the repaired tendons are intact, but there is a lot of scarring there, and that's how we just carried out with we went away with the tenolysis, and we got this patient's movement back. For the reconstruction, you can have palmar longus tendon grafts, which I've already shown in one of very few case scenarios over there. Plantaris is another tendon graft which you can consider. For pulley reconstruction, you can use one of the FDS slips or palmar longus tendon graft for the two-stage reconstructions, wherein this tendon graft can come around the bone, which can act as a pulley. And subsequently, you can use a silicone rod as a spacer. 6 weeks to 2 months, minimum 6 weeks we need for the joints to get supple, and then the second stage with the final graft repair site comes into play. So to take home, it's a purely clinical diagnosis, but ultrasound adds substantial value to decision making and execute the treatment plan, especially in delayed and late presentations. And for the reconstruction cases, ultrasound is very beneficial, which Lawande also has demonstrated very well. Goals of surgical repair and good supervised rehab are the constants of favorable functional outcome. Along with good surgical repair, supervised rehab is also crucial, wherein surgeons should actively take interest, and not only take interest, but have a good therapist standby, and he should be continuously supervising the therapy. Secondary reconstruction has multiple variables and to be addressed as per the case merit. I thank all my co-faculty, organizers, and the valuable audience giving time on Sunday evening. Thank you very much.
Thank you, Dr. Kiran. So we know that this is a very big topic. We covered in 10 to 12 minutes. So any questions for Dr. Kiran? In that aversion injuries of FTP, you put a button on the dorsal side. That button you remove what time?
Button we usually remove at around 4 to 6 weeks.
And now, if there is an injury to both the tendons in zone 2 and patient presents late, is it okay like we only do for the FDP part and leave the FDS. And if we want to take a graft, like you have taken a palmaris longus graft, in that situation, can we take FDS itself as a graft for FD?
So in delayed or late presentations, only FDP repair that is advocated, and that also, as in I practice that. FDS, taking only FDS as a graft, it depends on the case-to-case basis. If FDS length, you can harvest it well, or rather, if that length is enough, you can. Otherwise, palmaris longus is very very much beneficial, because you get a good length for the tendon reconstruction. And second thing, again, to reiterate, ultrasound gives us an idea whether patient has palmaris longus on the same side. Fortunately, these two cases, we had palmaris longus on the same side. So that's why we need not go to the other side, and we could very well finish the case on the same upper limb.
Great. Thank you, Dr. Kiran. So, any questions?
I can ask.
Yeah.
Time is there?
Yeah. Yes.
It was an excellent presentation, Kiran sir. Excellent videos and a series of cases. I just want to know what is the technique of your repair? You use 2-strand or 4-strand?
Regular modified caseless.
Okay.
With 4-0-ethylon core and 5-0-ethylon epitendinous, or if available, 4-0-proline and 5-0-proline.
And the rehabilitation, any particular protocol you follow?
The thermoplastic splint, the dorsal blocking splint, and I see these patients every 5th or 7th day myself. Then subsequently, when we leave the fingers open, I use that Coban tape for the edema control, and then gradually I stretch it out.
Good series and nice presentation, sir. Thank you very much.
Thank you, Dr. Latheesh.
Thank you, Dr. Kiran. So we move on further. I invite Dr. Deepak Malokar. So he is a hand surgeon from Akola, a very busy hand surgeon. So I would. So his topic is extensor tendon injuries. Dr. Deepak.
So can you hear me?
Yes.
So I must thank Dr. Manoj Godke sir and Dr. Abhijeet Wahegaonkar sir for giving me this opportunity. So I'll be speaking on extensor tendon injury. So vis-a-vis flexor tendon injuries, these are the injuries which are a little bit easier to treat, considering that these tendons do not pass through fibro-osseous tunnels, that is pulleys, and there are less chances of adhesion formation. But the challenging part here is to repair extremely thin and flat tendons delicately. So starting with these injuries, Kleinert and Verdun has classified these zones of injuries into 8 zones, to which the zone 9 was added by Doyle. So to remember them easily, the even numbers are situated on the joints starting from the DIP joint. So DIP joint is 1, PIP joint is zone 3, MCP joint is zone 5, and wrist is zone 7. So in between these, you have to add just even numbers 2, 4, and 6. The distal third of the forearm, where muscular tendinous junction lies, is the zone 8, while the proximal and middle third of the forearm is the zone 9. So let's go according to zone wise. So coming to zone 1 injuries. So these are basically mallet injuries. I will not be covering bony injuries, only soft tissue injuries will be covered. X-ray was done and there was no fracture seen. So basically this was a soft tissue injury, extensor tendon injury in zone 1. So these kind of injuries can be treated in a closed manner, can be treated conservatively using these kind of splints, which are malleable thermoplastic splints, which are readily available in the market. So these splints are generally bent and then used on the volar aspect. So while treating this injury conservatively, which I consider it is more difficult to manage, because the splints needs to be worn 24/7 for almost 6 weeks. And whenever it is advisable to use two splints, one splint can be used during while taking bath, because it can get should remain in extended position, which can be done with the ipsilateral thumb of that hand, keeping DIP joint and extension while cleaning of the finger is done. And physiotherapy is the most important part, where when the splint is taken off, we have to gradually start active as well as passive stretching. So this patient was treated conservatively using this kind of splint. And this is at around 6 months. He has complete extension. The extension lag is not there. And that's the kind of flexion. And this is the composite flexion. Coming to zone 2, these injuries are mostly open, and repair of tendon is necessary. Primary repair of the tendon is necessary, which are very thin and flat and has to be done delicately. DIP joint has to be kept in extension using the splint or K-wire, and rest of the management can be done as it is done in zone 1. Coming to zone 3, this can be closed or open. Like in this patient, it was a closed injury. There was no bony injury. So we did a modified Elson's test, wherein the PIP joint is kept in 90 degrees, both the hands, and they are pressed against each other. So normally DIP joint is flexed, but when the central slip is injured, when there is zone 3 extensor and tendon injury, the respective DIP joint is less flexed, and that is how you can diagnose the central slip injury. So in this patient, there was central slip injury, which was managed conservatively. So whenever we are managing central slip injury conservatively, we have to use this kind of splint on the volar aspect, so that the PIP joint is kept in neutral position or slightly extended position. But then care has to be taken that the DIP joint is kept free, and it is kept continuously flexion and extension, so that the lateral bands are not dislocated volarly. This is how she came to us at around 6 months, from what it was at around at the time of injury. Sometimes we do get to see these open injuries, like in this patient. This was an incised wound due to a sharp object, and this video was taken after giving block. Here you could see there was an extension lag of the PIP joint. On exploration, the tendon as well as the capsule were closed. There was no any joint injury, no osteochondral defects. So this was sutured primarily using a horizontal mattress suture and a figure of 8 suture, because the fractures, and they have a tendency to form adhesions with the underlying fracture surface. This patient had multiple fractures. So first, the fractures was fixed with K-wires, and then the wound was extended proximally as well as distally, and there was zone 4 extensor, complete division of the zone 4 extensor tendon, which was repaired with Ethilon 40. And this is how he came to us at around 6 months with healing of the fractures also. Coming to zone 5 injuries, zone injuries sometimes do present with an extensor tendon loss. Like in this case, this patient had extension lag of the middle finger. Here you can see on the tenodesis effect after the block was given, the middle finger is lagging behind. On exploration, there was almost 6 centimeter defect of the extensor tendon in zone 4, which was then reconstructed using palmaris longus graft of the same limb. And there was also skin loss, which was then covered with the Cobba flap. So this was the flap was elevated. The tendon gap was reconstructed using palmaris longus, and that's the post-insert defect. And this is at around 14 days, and this is at around suture removal. And this is how we send a photo on WhatsApp at around 5 months. He has a complete flexion. There is some little bit lag of middle finger at the IP joint, but then he is able to do all his activities of daily living. Now coming to zone 5, now this zone of injury, the special scenarios are the fight bite injuries, where when the patient is involved in altercation and the tooth, there is injury at the knuckle of the hand. First of all, these injuries generally look innocuous because the injury is very small, but then they are quite deceiving. And what we have to stress here is the injuries, the different level of injuries to bone and soft tissue. Because when someone hits someone else, the hand is in flexion, and the moment the fingers are extended, so the different level of injuries will be there to bone and soft tissue. This has to be kept in mind. And the third and most thing is this. Although looking innocuous, these injuries always need to be operated under anesthesia and a tourniquet. Otherwise, a pyoarthrosis or infection would lead, and that would hamper the complete function of the hand. Another injury which needs to be mentioned in zone 5 injury is the sagittal band injuries. These bands are generally situated on the radial as well as the side of the extensor tendon, and they help to keep extensor tendon in the midline. But the most important function of this extensor sagittal band is to extend the MCP joint, because if you can see, extensor tendon does not have any direct insertion over the bone, that is proximal phalanx, as it has on middle phalanx and distal phalanx. So this young patient, had a slicing injury to his index finger of the dominant hand. He had an oblique fracture of the proximal phalanx. This was post debridement. So there was fracture, and along with that, there was a ulnar sagittal band injury of the index finger. So first, the fracture was fixed with interfrac screws, and finally, the sagittal bands were repaired using horizontal mattress suture using ethylone force. Just this recently done case, so I don't. And this is how it came to us at around.
Able to hear you, Dr. Deepak. Dr. Deepak, you please unmute yourself.
Now you can hear me?
Yeah.
So this is a young patient who, this was a 2 months injury, incised wound again. There was a laceration which was just sutured at around the base of the metacarpal in zone 6.
Dr. Deepak, your screen is not visible. Can you share your screen, please?
Okay, sir. 1 second. Now it is visible?
Yes.
Okay. We are on zone 6 only. This is a 2 months old injury in a young boy. There was a laceration at the base of the metacarpals, which was just sutured. And once it healed, this patient had extension lag of the middle finger, which was hampering its grip also. Here you can see. So we had taken him surgery. So on exposure, we could find the distal end, but the proximal end was not found in the same incision. So we had to take another incision in the proximal middle third of the forearm, where we could locate the proximal end of the tendon. This was then delivered into the distal wound, and it was sutured. It was then sutured using an Ethylon 40, and this is his result. And as stated, the flexion has to be the flexion cannot be limited. And this is his. There is an independent extension of all fingers present, considering middle finger also. Coming to zone 7 injuries, these injuries are over the wrist joint, and this is where the extensor retinaculums are present. So this was an incised wound again in a young boy. He was assaulted by his own father, and these were the tendons. So except for the index finger and thumb, all rest of the extensor tendons were injured. These were repaired primarily using Ethylon 40. This was post-repair photo, and this is his at around 1 year status. Now, similar injury, but mode is different. This was a middle-aged man. He presented to us with an extension lag of index finger. Flexion was good, and there was swelling over the dorsum of the hand. There was swelling over the dorsum of the hand. On further probing, this patient had undergone nailing for the radius ulna shaft fracture almost around 10 years ago. And there was an attempt made to do a implant removal almost 4 years ago, where ulna nail could be removed, but the radius nail could not be removed. And patient just almost 15 days ago had snapped, heard a snap, and after that he was not able to extend his index finger. So basically, this is an attritional rupture of the index finger, wherein both extensor indicis proprius as well as the slip of EDC to index finger both were injured. So the nail was removed, and this was the index finger. EIP as well as EDC were seen. So in attritional rupture, it is very difficult to find proximal ends. So it is not possible to do a repair as well as to do a reconstruction. The only option in this case was to do a side hitching to the adjacent normal extensor tendon. So in this case, the EIP was in like side hitch to the middle finger EDC slip, and this is his healed picture, and this was his. Sorry. Now coming to zone 8 and zone 9 injuries. Now in these injuries, the most challenging part is that we will not get two good ends to repair, because this will be almost a muscle bellies, and there will be just thin fascia which we can suture. And here the suture material to be used is always a slowly absorbable suture like an vicryl. And the other thing we have to which needs consideration is whether it is only extensor tendon injury or is there any associated posterior interosseous nerve injury. So to differentiate between these two is, like in this case, we have to look for extension of the thumb. So whenever extension of thumb is present in proximal forearm injuries, the PIN is intact and it is only extensor tendon injuries. But whenever extension of the thumb, like in this case, is absent, then both extensor tendon injury and posterior interosseous nerve injury is present. So in this case, both extensor tendon as well as PIN were injured. This was explored, and here we could see there was PIN injury, and there was also damage to some part of the segment of the PIN. So we had debrided the posterior interosseous nerve toward healthy ends, and there was almost 2 centimeter defect. So this was grafted using a sural nerve graft, and following that, the tendons, the muscle bellies were repaired using absorbable stitches. This is at around 2 years follow. Luckily, everything recovered well. And thumb, basically, similar type of injuries will be present. The only zone of injuries will be less, because in thumb there is one phalanx less. But the management is same as per the management of the fingers goes. But the one entity which definitely requires mention is the attritional ruptures of EPL. Like in this lady, she was a staff at a hospital. She was not able to extend her DIP joint of the thumb, dominant hand, since almost 1 month. And again, further probing, she had undergone radius ulnar nailing for the shaft of the fracture of the shaft of the radius ulnar. So this is how, again, incision were made, implants were removed, and this was the ruptured end of the EPL. So as it is stated in attritional rupture, it is not possible to do a repair or do a reconstruction. So in this case, extensor indicis pollicis was transferred to the extensor pollicis longus. And this is post repair, and this is her function at around 6 months. So coming to physiotherapy, so as far as extensor tendon injuries are concerned, like flexor tendon injury needs to be moved from the second day. In extensor tendon injuries, we generally have to wait for 4 weeks. And following that, we can start active composite flexion along with active assisted extension. And one thing we need to stress to the patient that the extension lag, even after repair, will almost last up to 3 months. Otherwise, this patient become panicky. But they we don't have to be after them like in flexor tendon repairs, where we have to be after them. We have to see them at almost 5 to 7 days, and we have to do a supervised physiotherapy. extensor tendon injuries are a little bit forgiving also. Thank you.
Great talk, Dr. Malokar. Really very informative and in-depth coverage of every aspect of extensor tendon injury and repair with reference to the zones that are present. So thank you so much for it.
Thank you, sir. Thank you.
Thank you. Any questions from anyone for Dr. Malokar?
Deepak, hi. Abhijeet, sir.
Yes, please. Yes, please. Go.
Deepak, repair, as Dr. Latheesh asked me, your repair pattern in extensor tendon injuries? The suture.
Sir, I generally, I use Ethilon 40, sir.
Okay.
And I use horizontal mattress suture. And to just reinforce, I use a figure of 8 suture. That's all.
Okay. And then second question, EIP to EPL transfer you did.
Yes.
Do you get full Kapanji position back? There's always some lag to it.
Yes, sir. Always. They will actually get almost up to 8 or 9, but I am like, I have not follow up long enough to see whether they had reached almost 10. But 8, 9 I have seen. 8, 9.
Okay. Thank you.
Thank you.
Right. Thank you, Dr. Deepak. It was a very nice presentation.
Thank you, sir.
So we move on further. I invite Dr. Abhijeet Wahegaonkar. So he will be talking about ligaments, TFCC, scapula unit ligaments. He is a hand surgeon. There is no need of introduction, but he's a hand surgeon from Pune. Dr. Abhijeet.
Thank you. Thank you very much. It's always a pleasure to be a part of academic proceedings, even on a Sunday evening. My task is to speak about ligament injuries, and I'll begin with TFCC, and then if time permits, maybe we can cover a little bit of scapula unit injuries. TFCC injuries are very common, and the recognition of this injury goes back to 1771 when the French surgeon Dassault, he described this injury, and then in 1981, Palmer and Werner came up with a classification that is very commonly recognized and is used for the injury classification. And we all now also recognize that it's a major stabilizer of the distal radial ulnar joint and the ulnar carpus. It is triangular in shape, and hence the name triangular fibrocartilage complex. It connects the radius and the ulna together, and also the carpus to the radio-ulnar articulation. And then it has got several insertions from different ligaments, such as the ulnar lunate, the ulnar triquetral ligament, and then also the dorsal and the volar radial ligaments, which are also confluenced with the capsule. And this entire structure kind of forms a hammock, which is referred to as the triangular fibrocartilage complex. Triangular because it's triangular in shape. Fibrocartilage is the content of the ligament, and then complex because there are multiple ligaments that contribute to the formation of the structure. These are certain cadaveric sections and dissections to show the anatomical components of the ligament. Here you can see this is the volar aspect and the dorsal aspect, the volar and dorsal aspects of the TFCC. The central aspect is quite thin. This is the radial insertion, and this is the foveal insertion onto the base of the fovea. This histological slide is from the work of Toshiyasu Nakamura from Japan. This is a coronal section of a HNE staining of the fetal wrist, and you can see that there are Sharpie's fibers which go on to insert to the base of the styloid in the fovea, and this is the area which has the strongest attachment to the ulna and is perhaps the most robust structure that gives stability to the distal radial joint. So the function of the TFCC is stabilization of the distal radial joint, and we have to recognize that the distal radial joint is a load-bearing joint. We'll see that in a little bit. And then the load is transferred from the hand onto the radius, onto the humerus, so the humeral joint. And then it also plays a very important role in the pronation and supination movement. So if you see this slide with these pictures here, wherein you can see the forearm going through a range of pronation into supination. While stabilizing and holding these weights, you will understand how the DRUJ functions as a very mobile and a load-bearing joint at the same time. And let's understand in a little bit more detail. This is a schematic diagram with the musculotendinous units around the forearm. You have the most proximal muscle, which is a brachialis, that goes on to insert onto the ulna, just a little distal to the coronoid process. You have the biceps brachii muscle, which inserts onto the tubercle here. We have the brachioradialis muscle that inserts onto the radius. We have the interosseous membrane, and then you have the thumb abductors and the other muscles, the pronator quadratus more distally. And all of these muscles are very important in not only load transfer, but also in stabilizing of the forearm axis and the TRUJ as well. And then if you look at these line diagrams now, as the forearm goes from pronation into supination, it is the ulna that remains stable, and the radius will rotate around the ulna. And the very strong compressive forces that are acting at the distal radial joint will now be converted into very strong shear forces as it goes from mid-prone to either pronation or supination. Let's see this in this video, this cartoon here. So this is a fully supinated position of the forearm. You can see that in this position, obviously, there are very severe or very high shear forces, and the compression is almost zero. And then as the forearm comes into a little bit of more pronation, the compressive forces start acting at the DRUJ. And then in the mid-prone or the neutral position, we have only compressive forces and zero shear forces. And then as it goes on to further pronation, the shear forces will start increasing with reduction in the compression forces. And then again, in the full pronation, we have only shear forces and zero compression forces. So there are certain structures that nature has provided to mitigate these loads that are acting across the DRUJ. And what are these structures? To mitigate compressive loads, you have the brachioradialis, which is exerting an opposite kind of a pull to mitigate the compressive forces that are acting at the DRUJ. And then to mitigate the shear loads, we have the TFCC and the dorsal and the volar radial ligaments. And you can see how these forces are mitigated as a forearm goes into any rotational movements other than the absolute mid-prone position. So is it only the TFCC that is the stabilizing structure of the DRUJ? No, absolutely not. There are several stabilizing structures, and we need to recognize them. So besides the TFCC, we have the ulnocarpal ligaments, the subsheath of the extensor carpial narrus, the pronator quadratus, and of course the radial ligament, interosseous membrane, and more so the distal oblique band of the IOB, the interosseous membrane, IOM. These injuries result from a fall onto a outstretched hand, and usually there are axial forces with some rotational forces. And then these may be associated with fractures also. Clinical examination, of course, evaluation includes a very thorough history where we look in for any specific pain that is associated with clicking or any clunks, history of a fall or trauma, mechanical symptoms that improve with rest and worsen with activities. And the clinical examination involves looking for this instability pattern with these ballotment, shuck, and shear tests in different rotations. So you look at it in 3 rotations, in the pronation, mid-prone, and the supination kind of position. And that will put into evidence the instability of the DRUJ. Investigations include standard films, which include the neutral posterior or anterior view. Now, we often confuse the anterior posterior and the posterior anterior view. Remember, this is the neutral posterior anterior view where the shoulder is in 90 degrees of abduction, the elbow is in 90 degrees of flexion, the wrist is in neutral, and you have a perpendicular incidence onto the radius, onto the wrist joint to get a what is called as a neutral view. The neutral view is important because it is the only view wherein we can comment upon the variance of the ulna and the length of both bones. So get that view. We also get a semi-pronated and a semi-supinated oblique views. A dynamic view or a provocative view can also be done. And of course, this is often coupled with either an MRI or a CT arthrogram. The treatment for any patient who presents with a suspected or an established TFCC tear depends upon certain answers to these questions. The first question is whether the TFCC is repairable or not, or whether there is any damage to the cartilage and the cartilage is intact or not. And based on the answers to this question, we also have the stages of the injury. And if the answer is yes to both of these questions, we go ahead and perform a TFCC repair. If it is not repairable and the cartilage is still intact, that is to say there are no degenerative joint changes, we use a tendon graft to perform a ligament reconstruction. Case in point or an example is the Bryan Adams procedure or the modified Nakamura procedure. If the cartilage is damaged and if the TFCC is repairable yet, you would do some kind of a salvage procedure using an implant arthroplasty, but we don't have those available in India. And then we perform salvage procedures for conditions where there are established arthritic changes. So again, to show you how the instability pattern appears, we have already seen that in the previous video. You have several options to repair this kind of a scenario or a presentation, either using arthroscopic or open techniques. This is a schematic diagram showing the use of and a suture anchor using the open technique. Or you may even do a ligament repair onto the radial aspect, type 1D kind of repairs. You may also do a centralization or stabilization of the ECU onto the dorsal aspect, along with a TFCC repair and so on and so forth. But the standard of care is usually an arthroscopic evaluation and repair or reconstruction as required. We do perform this procedure under a regional block and the standard arthroscopic technique where the wrist is distracted with vertical traction. And then you have certain landmarks which begin with identifying the Lister's tubercle and the distal ulna along with the distal radius. And then that gives you a clue to where your extensor pollicis longus would be. We also go ahead and mark the basis of the second and the third metacarpal. And then we now have a clue to the location of the extensor carpi ulnaris, the fourth extensor compartment. And then the soft spot is palpated just a thumb breadth distal to the Lister's tubercle. And we identify that soft spot, and then you insufflate the joint with about 3 to 4 ml of saline, and you can see the pushback on the piston that indicates that you are in the joint, and this egress of the fluid would let you know that you are in the right spot. We make a very small incision, restricting ourselves only to the dermis and not going any deeper because you do not want to damage any deeper structures such as the tendons and the nerves. And then using the hemostats and the index finger as a block, we make a capsulotomy. You feel it as a small pop, and then you bring in your trocar and your cannula with a small joint arthroscope, a short barrel arthroscope. This is a 1.9 millimeter arthroscope that's going into the joint, and that would give you an opportunity to peep into the joint and perform your diagnostic round of arthroscopy. We begin with dry arthroscopy initially, and then we bring in the saline ingress. At this point in time, we bring in our outflow cannula, which is usually the 6U portal. And then at that juncture, we make our viewing portal, our primary portal, and then the secondary portal is your outflow portal. And then the third portal that we make directly under vision is your working portal. This is usually the 6R portal. So when I'm using 6R, 6U, or 3-4, we are referring to the extensor compartments and then the portals between these extensor compartments. We have to prevent any injury to the veins that are very clearly visible through the transillumination, and you stay away from those veins. You use a hemostat to spread the tissue gently so as to prevent any injury to the nerves. And then at this juncture, again, you pop your hemostat into the joint, and then you have your access to the joint through the working portal. Here is an example of a peripheral tear of the TFCC. This is the lift-off test. You can see my hook probe trying to lift up the TFCC. And then we begin with shaving that aspect. This is something called as a suction test. As I bring in my shaver and you start the suction, the TFCC gets pulled into the suction cannula of the shaver. That indicates a full thickness tear of the TFCC or a foveal avulsion. The repair is performed using either absorbable or non-absorbable braided suture, depending upon your preference and choice. And we either perform a peripheral repair, something called as a capsular ligament repair, or we perform what is called as a foveal reinsertion of the TFCC using suture anchors or a mini push lock, and we'll see that in a bit. So this is what is called as a go sign or the wave sign or the lift off of the TFCC. You can see that there is a complete avulsion of the TFCC from the fovea, and the end outcome should be a stabilization. This is the same patient that we started off with, and we can see that a transosseous or a foveal reinsertion of the TFCC can be done. We prefer to use mini push lock suture anchors, again, no conflict of interest. So after you have placed your horizontal mattress suture, we bring out these sutures through the 6U portal, make a small incision, wherein we bring in a small K-wire to make a pilot hole, which is usually a 2.5 millimeter hole. And then we drill to a depth of about 8 millimeters to put in the mini push lock, and then placing traction onto the suture limb, we fix the suture limbs to the metaphyseal area of the ulna, distal ulna, so as to provide a very robust repair and a stabilization of the TFC. So we don't have to use a suture anchor, and this allows you to put traction on the suture limbs and then perform a more stable repair or a more robust repair than a suture anchor where you're going to push the knot down in a very tight area. What about chronic irreparable TFCC injuries? Appreciate the incredible instability that is present here. Now, in these cases, we usually perform a ligament reconstruction using a tendon graft. The most frequently performed procedure is the Adamberger procedure or the modified Nakamura procedure, wherein you make these tunnels into the radius and the ulna, and then you borrow a tendon graft and you weave it through the radius and the ulna in a figure of 8 manner so as to reconstruct the dorsal and the volar radial and ligaments and provide stability. So this is the same patient that we saw in the earlier video with the remarkable instability, and now you can see that this joint is rendered completely stable by the ligament reconstruction procedure. Post-hoc protocol usually involves using an above elbow splint with the forearm in full or near full supination, and the wrist in slight extension and ulnar deviation from anywhere between 6 to 8 weeks, depending upon what repair and the robustness of the repair that you think you have done. Then we begin gradual active and assisted range of motion exercises, and then we graduate on to strengthening exercises. More often than not, these patients will be able to return to pre-injury level of activity, including sports. However, no procedure is bereft of any complications or problems. And the usual complications that we find, although rare, are either injuries to the superficial nerves or superficial infection. And the remainder are quite rare, but we may also see some reflex sympathetic dystrophy and stiffness, tendon ruptures. And this is especially because of very unjudicious use of thermal cautery or RF for that matter. And these have been reported in literature. It's always nice to have a training and kind of a cadaver course before you make a foray in performing wrist arthroscopy and using wrist arthroscopy. So how to avoid these complications is, of course, by training, using proper instrumentation, being very thorough with the clinical examination, proper patient selection and counseling, attention to the technique and the details. As they say, the devil lies in the detail, and of course, having a proper rehab program for your patients. So with that, I thank you for your attention. And if time permits, I'll be happy to take up the scaffold unit, or maybe we can then move on to the next talk. Thank you very much.
Thank you, Dr. Abhijeet. It was a nice talk. Many times when we fix the distal radius with a plate, and you find that on table there is a lot of allotment, maybe because of TFCC injury or the. So in that situation, is it advisable to do the repair on table, or you wait? What is your protocol?
Good. Thank you very much for raising that question. This is a question that hounds a lot of our friends and colleagues. So assessment of the DRUJ with a distal radius fracture is on the premise that you have restored all parameters of the distal radius, by which I am referring to the length of the radius, the inclination, as well as the volar tilt of the radius. Now, if you have restored all of those parameters, and then you examine the DRUJ for instability, and you do that in 3 rotations again, pronation, mid-prone, and supination. Now, we are also taking into consideration whether it is an ulnar styloid fracture or not. There are several studies to suggest that not every ulnar styloid fracture needs to be fixed. So, rule of the thumb, if your DRUJ is unstable in pronation and mid-prone, but stable in supination with your radius being appropriately fixed, you would then just immobilize in an above elbow slab or cast for about 6 weeks. That usually stabilizes over a period of time. However, if the DRUJ is still unstable in supination, then something needs to be done. If that ulnar styloid process is large enough to be fixed, you may use any modality of fixation. You may use K-wires, tension band wiring, headless compression screws, a hook ulnar plate, whatever. Or you may just go ahead and repair the TFCC if the styloid fragment is very small. Let us extrapolate this information from a GT fracture. The cuff is important. The cuff is the major injury, and the fragments need to be fixed along with the cuff. So you're basically repairing the cuff to restore the integrity of the rotator cuff. So likewise, in the DRUJ, the styloid fragment is an indication of an avulsion injury of the TFCC, and it should be treated as such. However, the commonest reason why we will have a DRUJ instability in the absence of a styloid fracture is a lax interosseous ligament, because we have failed to restore the parameters of the DRUJ, and that should be addressed, and that should always be kept in mind. So I hope that answers the question. Thank you.
Thank you so much.
Yes,
I have a question.
Ashwath, yeah.
Sure, Ashwath, tell me.
Sir, we often get students who come with this wrist pain, ulnar-sided wrist pain, and when we do the MRI, it often shows partial TFCC tear. So, what is your regime for conservative management, and what is the type of splint or therapy you offer for students, or this kind of sports injuries? We often, before you start thinking about surgery.
Good question, Ashwath. So my disclaimer here before I answer this question is I'm not a trigger-happy surgeon. So I think everyone should understand that we do not recommend surgery for every person who walks into the outpatient clinic. So we always do a very thorough examination, and any kind of instability, especially in girls or young athletes, we always look for constitutional laxity, and we rely on the Baton score. We always examine the opposite wrist in all instances. And then in the absence of a very frank injury, they often complain of a vague kind of an onset. It's an insidious onset. And in these patients, we usually begin with an immobilization and recommending complete rest, avoiding any strenuous kind of activity. With proper counseling, even a well-molded below elbow splint is good enough because that will prevent pronation supination to quite some extent. However, if a patient is non-cooperative, then we would advise an above elbow splint. We usually recommend that people use the splint for anywhere between 6 to 8 weeks, and majority of them will have reduction in symptoms, at which point in time we will begin gentle range of motion exercises and then gradual strengthening exercises while still maintaining the splint. So we ask the patients to use a splint, and we give them a ballpark figure of 6 months, 2 months of immobilization, 2 months of range of motion, and 2 months of strengthening exercises. And we advise them very categorically not to do any kind of strenuous activity, including weight bearing and lifting, for about 6 months, and they usually will get better. Now, in that small cohort of patients who really do not get better and who keep coming back, and they usually then themselves ask for some kind of a robust way in which we can address the pain, and they qualify for surgery. Do we inject distal radioulnar joint? I do not remember the last time I gave a steroid injection in a non-arthritic joint, and especially young athletes and students. We do recommend some physical therapy in the form of ultrasound therapy or massage and heat and ice or contrast bath kind of a modality of treatment. We very seldom recommend analgesics. So rest, splints, and then graduated therapy. That's our usual protocol. Thank you.
Thank you so much, Dr. Abhijeet. So
I think we'll skip the scapholunate in the interest of time.
So we move on further. I invite Dr. Ashwath Acharya. He is a hand surgeon at KMC Manipal, and he will be talking on Holstein Lewis fracture humerus with radial nerve palsy and wrist trauma.
Hello.
Yeah.
Is my slides visible?
Yes.
Okay. So I'll be talking on decision making in Holstein Lewis fracture, radial nerve injury. It's a major problem in our general practice. We very frequently come across this kind of problem, and often the controversy is whether to operate such fractures. Quite often, because literature do tell that these are amenable for conservative management, whether to explore and fix such fractures. And the next point is whether to explore the radial nerve, because quite often we don't explore the nerve, but this is one area where we often go by the posterior approach. We can explore the nerve, and but when you think about conservative management, whether to explore the radial nerve is a very important question. And the other important aspect is how long do we wait for the recovery to happen. So anatomically, if you see, there are two important sites where the nerve gets here. One is somewhere at the mid shaft near the spiral groove, where the nerve is vulnerable. But what you see here is usually the nerve is not in contact directly with the bone. So at least about a centimeter, or maybe sometimes even up to 5 centimeter thickness of muscle may be there, which separates the nerve from the periosteum. But it is at this junction where it enters the lateral intramuscular septum. That is the most vulnerable area where the nerve is liable to get injured. Usually, the classical teaching is it is somewhere near the distal third. But of late, new cadaveric studies have shown that this is not necessarily so. It's somewhere near the mid shaft where the nerve starts entering the anterior compartment. It is this area which is the most vulnerable area where the nerves may be susceptible to traction. So the nerve is susceptible particularly to injury, particularly if it is a fracture at the middle third or the distal third. And these kind of injury could be primary or secondary. So primary means there is a direct injury from the fracture, and secondary is because of subsequent scarring or some callus entrapment may cause injury or fibrosis. Now, what is this Holstein Lewis injury? Okay, it's all started in 1963 with the publication by that Holstein and Lewis from the US, where they presented 7 patients, which had 6 of them had a radial nerve entrapment at the distal third fracture site, and 1 of them turned out to be laceration. And it was they who first talked about strongly advocating surgery to release the nerve and fix the fracture. So subsequently, after that, there is always have been a controversy about whether to manage such injuries conservatively or not. So how frequent is this problem of radial nerve injury in Holstein Lewis? So there are actually very minimal studies. There are only 2 studies on that, which has exclusively looked into that. And the most recent one is from Swedish group, which is one of the largest studies where out of 327 patients turned out to be Holstein Lewis, which is around 7.5% of all the humerus shaft fractures. And how frequent is the radial nerve injury in such patients? And what they tell is it's around 22%. It's quite high. Okay, so the risk of acute nerve injuries in Holstein Lewis is quite high when compared to the general shaft fractures, which is around 8 to 12%. And what they have observed is there is no difference between non-operatively and operatively treated patients. So if you see overall incidence, how frequently we come across nerve injuries, which is around 10 to most of the studies, including systematic reviews, they say it's around 10 to 12%. And usually it is more frequently in the middle third and the distal third. So distal third being the most common. So somewhere in between the middle third, the middle half and the distal third. In that junction, the nerve becomes extremely vulnerable because of its very close proximity to the periosteum and also the tight compartment in the lateral intramuscular septum. Now, in the last 3 years, we have seen 3 systematic reviews, and each of them have given different opinion and conclusion. So, Asif Ilyas from US has presented his systematic reviews of about 7,000 fractures, and he tells that you must explore. Okay, so surgical exploration within 3 weeks of injury and had a significantly higher likelihood of regaining back the function. But a guarded approach has been given by, in the same year, they have another group have published where they say that while exploration demonstrates increased resolution, but they have not told which type of fractures would ideally be an indication for nerve exploration. And exactly opposite to those views, in another systematic review which involves around close to 2,000 fractures, Hendricks, okay, so that group, they say that there is no beneficial effect of early exploration on the recovery of function. And in fact, patients managed operatively had a higher risk of developing secondary radial nerve palsy. So exactly the opposite view suggests. So we are always in a dilemma, when any kind of literature which comes to particularly the controversy still goes on. But what I personally would like to rely on is this one very important paper which I read very long time back during my fellowship days. And the same author has also written the more recent edition of the Greens. Rolf Birch is a very famous name. Now he has written a lot about peripheral nerve injuries, and as far as radial nerve is concerned, what he says is, so when the repairs, when you do exploration and repair of this nerve within 14 days, there is 49% of achieving a good results, which is half of them will actually do well. Whereas the moment you delay a little longer, almost you have 1/4, almost 3/4 of them will not do so. So this is one of the guiding factors which helps in management of radial nerve palsy in such kind of injuries. So what is important is to understand the pattern of injury. Okay, so when you come across such injuries, it's extremely important to a thorough clinical examination. Okay, so you need to find out whether it's a complete injury or an incomplete injury, whether any partial chances of any important motor function is there, is the sensory function preserved. So that is very important to assess. And subsequently, if you are managing conservatively, you need to look for whether any signs of deterioration, like, for secondary changes. The callus entrapment is one of the major problems which we often come across. And there's a new classification suggested by Ilias, where they have told about different grades of injuries. So you can have stretch injuries. These are the most commonest. Okay, so almost 3/4 of them are basically stretch injuries, and they will respond extremely well within a month's time. Then you have the incarcerated ones, which are axonot misses. It has different grades. Then you have the partial transections, partial lacerations, or the most worst case scenario are the complete transections. But how do we actually assess this when you have closed injuries? Now, the answer is basically you need to have a very careful clinical examination of such cases. And generally, NCV, EMG are useful only at around 3 weeks' time. So if you're managing it conservatively, so one important aspect that we need to look for is the amplitude, okay, and the conduction velocity. So whenever there is demyelination, which is neuropraxia, so in that situation, the amplitude is preserved. Okay, so there will be some conduction, but the amplitude will be less, but nevertheless, the conduction will be there and the velocity will be slowed. Okay, and it rapidly improves by around 3 weeks' time. Whereas the moment you see axonal loss, okay, both the amplitude and the conduction velocity will be, it will slow down after some time. So the distal latency will generally be preserved, and similarly, in demyelination, there will be significant prolongation of the latency. But overall, generally, what we see is the difference between the amplitude and the conduction velocity. Now, another very important tool is the EMG. So this is in fact one of the most important tool we rely on, particularly when you compare with the clinical side. Initially, it will be normal in the first 10 to 12 days because Wallerian degeneration has not set in. But as you see, by 16th day or 1 month's time, you'll start seeing fibrillation. So the moment you see fibrillation, you're sure that this is definitely not neuropraxia. That means the injury is much more severe. And you need to carefully observe such cases. And by around 2 months' time, you will start seeing polyphasic potentials, particularly involving the brachioradialis, ECRL, and so on. If that is the case, most probably you're dealing with axonotmesis, and you can offer a good prognosis for such patients. So 2 months is the yardstick which is to be suggested. But if you don't see polyphasic potential, then you have to presume that this could be perhaps neurotmesis. Another very important tool which helps, there's so much of nice videos and photographs. Earlier, Dr. Ashwin Lawande had presented such beautiful images we saw. And this is perhaps another excellent indication for ultrasound, where you can actually see the fascicular pattern of the nerve. You can see the edema, compression, or any twisting or torsion, or in fact rupture also. Now this is images from a textbook which shows a lot of edema happening in the nerve following a fracture, or sometimes we see severe compression, disturbance of the fascicular pattern. And based on clinical observation and correlation with EMG, you can actually offer a fair amount of prognosis and predict the type of recovery. Now here is another example where you can see that there is torsion of the nerve. There is some twisting effect, the fascicular and the fracture getting entrapped in the fracture site. And similarly, a diffuse compression of the nerve from the fracture site on one side. And this is how the normal nerve looks like. And this is the compression of the nerve. So beautifully, ultrasound can guide us exactly the type of injury, whether nerve is ruptured, and also beautifully guide us on the approach that we should go for. So what are the arguments for early exploration? So as suggested by one of those systematic review, Dr. Ilyas, what he argues is that early exploration allows for early nerve injury characterization. You can classify the injury. Okay, this is one of the biggest benefits. The moment you see the nerve, you know the prognosis. Okay, and it is technically easier and safer than late exploration because the nerve can be nicely delineated from the clots rather than the fibrosis, the dissection time. So much of scarring involved in late exploration. And early exploration and nerve repair leads to obviously superior outcomes. You can in fact retrieve the nerve from incarcerated, or the transected nerve can be brought and approximated. Okay, so these are some of the major benefits of severe injuries. And of course, exploration will decrease the chances of secondary entrapment callus or compression from these scars in and around the fracture site. Okay, and the treatment plan for such fractures generally is based on the fracture geometry. Obviously, you can, most of the surgeons would manage these injuries by fixation. And all the more important that when you have a nerve injury, invariably, most of the surgeon would like to explore, particularly the Holstein Lewis injury, with the notorious reputation it has, and also the recent publication where it showed almost 1/4 of these injuries actually will end up with radial nerve palsy. So primary exploration would be one of the best way to address the problems. And generally, the posterior approach, the modified posterior approach, will give access to almost 94% of the shaft of the humerus. And once you explore the nerve, expose the nerve, once you have fixed the fracture, you can then delineate and define the nerve. Okay, so there's a new classification, and it is this classification which will guide us in how to manage such injuries, particularly with Holstein Lewis. This is very useful. So one is the stretch injuries. For obviously neurolysis is the answer, And a systematic review by Ilyas has shown that when you do neurolysis for such injuries, the results are almost, recovery rates are almost 90%. Excellent results with neurolysis. Whereas when you manage it conservatively, the chances of complete recovery is around 75%. Now, in case of incarcerated, again, this is one of the best where you can do extrication of the nerve and free the nerve and do a neurolysis. And partial transection and complete transection are amenable for repairs. There is an example of a fracture where we did a neurolysis. The nerve was entrapped. This is not exactly the Holstein Lewis injury. This is more of a midshaft fracture with a wrist drop. Now, here is another example. This is a typical Holstein Lewis fracture where the nerve was found entrapped on the fracture site. So it is these cases when you do early exploration, there's a good chance of you can do a excellent job, particularly when you have microscope to your help, and you can delineate the fascicles better. You can free the nerve, and overall the results are much better. And obviously the secondary entrapment can be prevented, as I told earlier. And obviously, when you have injury, you can repair it. Here is one example where, where two of the important fascicles we repaired under microscope. So you have a better quality of nerve, and chances of grafting is almost nil, particularly when you don't delay the repair. The moment you delay a little more, the chances of grafting dramatically increases. Okay, so in case if you decide to wait for such injuries, how long do we wait? Okay, so patient has a Holstein Lewis, and some of the surgeons obviously, or when the patient is not willing for surgery, then one option, obviously one of the options as suggested by literature is you can put a plaster cast because the results are the same. But how long do we wait for the nerve to recover? So the important yardstick is clinical examination, and our age-old Tinel science still is one of the gold standards for that. So you should be looking for recovery of brachioradialis and early wrist extension by around 3 months' time. And serial EMG is to be suggested. At exactly 1 month. That will be the first NCV EMG, and again it is repeated at around 2 months' time. And there should be reinnervation signal to be seen, particularly with brachioradialis and ECRL. This is one of the important suggestions by Ilyas. And if there is no difference between these two studies, exploration at 3 months is suggested. So you can wait up to 3 months, and generally we don't wait for longer time. Now, what are the problems peripheral nerve surgeons face? When you have no recovery and you open these fractures at around, let's say, 4 months or so. So you see here one example where the radial nerve is entrapped in the fracture callus, and invariably these are the cases which will invariably require grafting. Okay, and perhaps these patients would have benefited from early neurolysis alone if you could do an extrication and free the nerves and wait and watch. Maybe perhaps he may have recovered with a better quality of function. So that is always one important thing, in certain specific cases. So obviously this patient required grafting, almost up to 10 centimeter grafting. But in general, radial nerve performs better than the other median and ulnar nerve. So even if you do grafting, since it's more of a pure motor nerve, the results are much better on recovering. But as I told earlier, if you delay more and more, then your chances of recovery becomes much lower. particularly doing repair after or close to 6 months, the results have always been less than satisfactory. Now, of late, a lot of people talk about nerve transfer, and it has particularly in delayed presentation. So, if you wait up to 6 months, so one of the options which they talk about is doing a nerve transfer. So here is one example of a nerve transfer. The major advantage is obviously you're repairing it very, very close to the target muscle, which is the extensors. Okay, so the posterior introitious nerve, we can take a fascicle from the median nerve and transfer it to the posterior introitious nerve. Similarly, a small fascicle from the FDS, and you can transfer it to the ECRB branch. Okay, and the major advantage is it's more of a motor-to-motor nerve transfer, and it can be done in delayed presentation because you are expecting a faster recovery. Obviously, the axons will have less distance to travel, and another major attractive benefit is the possibility of independent finger extension in such situations. Okay, although it's not present in all the cases, but select few cases may get independent finger extension. Thumb extension can become independent. So here is one example where we did a nerve transfer, and also later on actually we added on a tendon transfer because the finger extension didn't recover. So he has a very good extension at the wrist, which is purely working with the our nerve transfer, and subsequently he has undergone a tendon transfer. So nerve transfer can help in select few patients. Now, obviously, when these are more than 6 months, and particularly beyond 9 months, obviously you cannot do nerve reconstruction and all. The results are extremely poor. So obviously we go for tendon transfer. And one of the good things about such injuries is you can get very good function with the basic tendon transfers. So here is one example of tendon transfer, a standard modified Jones tendon transfer, where you can get fairly good function. So to summarize, always look and do a detailed clinical examination. Follow-up is extremely important. That's one of the key and still remains one of the important yardstick for our management of such injuries. And yes, investigation do help. I think we should be using ultrasound more often than what is suggested, because as we saw today, Dr. Ashwin's magnificent ultrasound videos, we should be using this more often. And yes, early exploration is extremely important to get good results. Thank you.
Thank you, Dr. Ashwath. It was a very nice presentation. I thank all the speakers, Dr. Ashwath, Dr. Kiran, Dr. Latheesh, Deepak, Abhijeet, and our Dr. Ashwin. And hand over to Dr. Abhijeet for the conclusion. Abhijeet?
Yeah. Hello.
I can hear you.
Hello.
Yeah, we can hear you.
I think it was an excellent presentation, Ashwath. I really want to take this opportunity to thank all of you, Malokar, as well as Dr. Lawande, who was here earlier on. Unfortunately, Terence was not able to join in. I had called him. He said he was busy initially, but I think he must be caught up somewhere. But this was a fantastic webinar. Every time I listen to you all, I learn so much. Wonderful presentations. I salute your commitment to advancing academics, sharing your knowledge and wisdom and your experience with all of us, and taking time off, on a Sunday evening as well. I'm very, very grateful to you. I'm grateful to OrthoTV, who has been supporting and encouraging these activities, and also to the leadership of the West Zone of the IOA for giving us the opportunity to undertake these teaching activities. Thank you once again. Have a wonderful evening, and we look forward to hosting you again sometime soon in the near future. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
So much.
Bye.
Thank you. Thank you.
Bye.
Bye bye. Poonam madam, thank you so much.
Thank you.
Take care.